was just. Here. Goes to the lobby of 6. Clean up to form since 7:30.
Okay.
Okay. That's
You should.
You're live. Good morning, everyone. I'm Ann Taylor, and I'm the Director of Community Engagement for AIM at Melanoma. I'm going to have an opportunity later on to tell you more about our foundation. But I just wanted to stand up here for just a moment this morning to thank the UC Melanoma and Skin Cancer Coalition, who have become wonderful partners for AIM at Melanoma. This is the third Melanoma Symposium that we have co-hosted together. We are so delighted to have them as partners in disseminating education about living with melanoma to the community. I want to thank Dr. Chao for serving as our moderator, and I want to thank all of our panelists for their collective wisdom. Now, I know that there's going to be questions for them. If you're in the room, UC has been kind enough to provide us all with swag bags, and in those are a little pad and a pen. If you'll write your questions down, we'll get those to Dr. Chao, and he will answer as many as we can during, we have 2 Q&A sessions planned for today. If you are joining us live, or via Zoom or Facebook or YouTube Live, we want to welcome you. Thank you so much for joining us today. We know we have well over 100 people who have signed up to join us, and we want you to know that we're glad that you're here with us. If you have questions for our panelists today, then what we want you to do is, if you are joining us via Zoom, if you'll look at your screen down below, you'll see a chat tab. You're welcome to say hello to everyone. Let us know where you're joining us from. But if you have a question for our panelists, please put that in the Q&A tab. And if you are joining us via YouTube or Facebook, if you'll put your questions into the comment section, we'll transfer that over into the Q&A session for our panelists. And with that, I am handing the podium over to Dr. Chao, and thank you and welcome.
Thank you, Ann. So on behalf of AIM at Melanoma, our national advocacy group, and the University of California Melanoma and Skin Cancer Consortium, I'd like to welcome our patients, our guests, and our esteemed panel speakers, and our industry sponsors to this 3rd annual Melanoma Skin Cancer Innovation Symposium. You'll notice we have this at our new Chao Family Comprehensive Cancer Center and Ambulatory Care building. Just a brief introduction. This building opened officially July 16, 2024, so it's very, very new. It joins our parent institution at the UCI Chao in Orange. This building is 225,000 square feet on 5 stories. Soon it will be joined by a 7-story, 144-bed general hospital, acute care hospital with an emergency room right next door. I'll do a shameless plug also for our UCI and our Cancer Challenge fundraiser that's coming in October 11, 2025. It's raised $6.7 million since its inception by our Cancer Center Director, Richard Van Etten, in 2017. It's a bicycle run and walk event held on the graduate campus just down the street. Finally, I'd like to offer my thanks to the people who really organized this event. Paige Soaps, our UC Melanoma liaison with the Medical Oncology Association of Southern California. Alice Twan, our executive assistant here in the Cancer Center. And Garth Taylor, you just introduced. And Denise Lanuti, wave your hand.
Outside.
She's outside. She's our senior director of development and cancer programs here at UCI. And with that, and without further ado, I'd like to initiate this Melanoma Skin Cancer Innovation Symposium. And our first speaker, we are lucky to have is Dr. Iwei Ye. She is a dermatopathologist from UC San Francisco, our partner institution.
Morning, everyone. Thank you to the organizers. Thank you, Warren, for inviting me. As Warren mentioned, I am a dermatologist.
Sorry.
I'm a dermatologist and dermatopathologist. In dermatopathology, what we do is we receive the skin tissue specimens that your providers will biopsy and send to us for diagnosis. So, the questions we ask ourselves every day in practice is this skin cancer? And you would think that it would be kind of an easy distinction, but it's often not. And so today I'll talk to you about kind of a little bit about our work and trying to understand what causes skin cancer. And that will help us to prevent skin cancer. Okay, well, so this is a histologic image of the skin. Just to orient everyone, the purple part at the top is the epidermis, the outermost portion. And then here we have the dermis. Here's a hair follicle. There's some solar elastosis here. We'll highlight that. Sebaceous glands. And when we're talking about, when we zoom in closer, we can see the keratinocytes are here at the surface. Then we have the melanocytes. They're almost very difficult to see, but they're these individual cells that are in the lower portion of the epidermis, and they make the pigment that protects our skin. And typically, they're just these single cells that are scattered in the basal layer of the epidermis. Then we might also have lymphocytes. And here we can see this bluish material in the dermis. That's solar elastosis, and that's a mark of UV damage that's been occurring in the skin. And we use that to kind of score how much solar damage has been occurring. Since this is a talk about skin cancer, I'll talk quickly about carcinomas of the skin. They're common, so there are common types and rare types. So squamous cell carcinomas and basal cell carcinomas arise from the epidermis that I showed you before. And then we have rare subtypes of skin cancers like sebaceous carcinoma, Merkel cell carcinoma, and other carcinomas. So generally, how does cancer develop? And it's considered to be a genetic disease that you accumulate genetic mutations that cause genes to become overactive, that tell the cells to proliferate, or break genes that are the natural brakes on the cell growth. It's called tumor suppressors. And it doesn't take usually just one mutation to progress to cancer. And we can actually see a progression in some cases where you first have, a normal cell, it acquires a mutation, you get a benign growth or a benign neoplasm that will grow into a pigmented lesion or a bump that will remain stable. That may accumulate additional mutations, and then we may have changes that we consider pre-cancer, still not cancer, but at a higher risk of becoming skin cancer. And then we'll end up with a cancer, either a carcinoma or a melanoma. So we can divide tumors into epidermal tumors and melanocytic tumors. Here's some examples of epidermal tumors. Here we have, can you see my arrow? Where's the pointer going? How about now? This is a solar lentigo, a seborrheic keratosis. This is an actinic keratosis, considered a precancer, where you have more atypical cells. And you can see this lesion is inflamed. There are lymphocytes here, so the immune system actively sees this neoplasm and is causing this inflammatory response. Here we have squamous cell carcinoma in situ. It's thicker, the cells are atypical, they're growing in a disorganized fashion throughout the entire epidermis. And then here in this lesion, we have a carcinoma where the atypical cells are now leaving the epidermis, going into the dermis and invading. And so that's carcinoma. So we can think about the progression stages of these different epidermal neoplasms from lentigo to seborrheic keratosis to precancers like actinic keratosis, and then finally to squamous cell carcinoma through the accumulation of mutations. Now, interestingly, there was a study looking at quote unquote normal skin. And so in this study, they took skin tissue from eyelid surgeries, blepharoplasties, and they took small samples from the eyelid and they sequenced those. And what they found was that there were these little clones within the skin. So the skin looked normal, but they could see that these different small patches had the same mutation within them, indicating that one of the cells in that area got a mutation and then started growing within a small area. And here you can see in this picture here, this is what the clones look like. Each circle here represents a patch of cells that all contain the same mutation, in this case here, a FAT1 mutation. And then the other circles contain additional mutations. So you can see that even in normal skin, you have an outgrowth of cells that have these oncogenic mutations. And when you look at normal skin, there's a certain number of mutations there. But when you look at the different skin cancers, both squamous cell carcinoma, basal cell carcinoma, and melanoma, you see that many of the tumors have a very high mutation burden. And it's been shown that these mutations carry a signature of UV radiation, so indicating that they're caused by UV exposure. Now on to melanoma. Looking at the genetics of melanoma and the clinical situations in which we see melanoma, we know now that melanoma is not one single disease, and we're working on stratifying them into different categories to help with diagnosis and giving patients an idea of their prognosis. There's the low cumulative sun damage melanoma, which is maybe one of the most common ones. This is the type that might arise from a pre-existing nevus. Then we have high cumulative sun damage melanomas. These occur on very skin with a lot of sun damage, and they may often occur first as a patch that spreads radially. We have acral melanomas that occur on the hands and feet and the nails. Mucosal melanoma can occur in the sinonasal cavity or genital urinary system. And then we have melanomas that may occur in the eye, uveal melanoma. We also have these congenital nevi, children that are born with large melanocytic tumors that are benign, but they have a higher risk of progressing to melanoma, so melanoma from congenital nevus, and then another subtype called Spitz melanoma. So when we think about melanoma, we have the nevus that occurs from a single mutation, and then melanoma occurring from multiple mutations. And then we have this in-between category, which we're working on figuring out, the melanocytoma, atypical nevus, dysplastic nevus, or melanoma in situ. So how does that pertain to you? By having these diagnostic categories and kind of sorting them out, we can figure out how best to treat the different lesions. So for the melanocytic nevus, we should leave it alone. It has a low risk of progressing to melanoma, so biopsy or surgery is not needed. For these tumors here, there's kind of some uncertainty about what is the best method for treating them. So typically these are treated with surgery, but the margins, how much extra normal tissue we take around them, it's not agreed upon by everyone. So we still need to kind of understand what is the risk of these lesions progressing. And then for melanoma, we have standard therapies. Here's again just a graph showing the number of mutations across all different cancer types. And melanoma, you can see here, on average, has one of the highest numbers of somatic mutations. Again, it's not, there's a wide distribution. So there are some melanoma subtypes that have very few point mutations, and we don't think that they are caused by UV radiation. So what are some strategies to prevent skin cancer? We want to avoid mutagens. So I think everyone probably knows that sun exposure is not good for you. You should avoid mutagens. And not only is that, seeking shade, using sun protective clothing or sunscreen, but we can think about kind of societal methods to avoid sun exposure. So in Australia, where they have a huge amount of skin cancer, for after school sports, they try to do them not at 3 p.m. when school lets out and the sun is pretty bright, but they put the practices that are outdoors early in the morning or later in the day to kind of avoid peak sun exposure. So we want to think about how, we can manage sun exposure for children through community mechanisms. Then there's also screening to detect precancers and early skin cancers. These can be modified based on personal risk. So if you have a lot of atypical appearing nevi, each of those nevi has some risk of progressing to melanoma. If you have 200 nevi, you're at higher risk than a person that has 10 nevi. In addition, we know that there are germline alterations that can be associated with melanoma. So if you have one of these conditions, you may need closer screening. Treatment of precancers, so destruction of things like actinic keratoses, excision of atypical nevi. Some people are now thinking of melanoma in situ as a pre-cancer, a pre-melanoma, so excision of those or topical treatments with immunotherapies, and of course, early detection. So we know for melanoma, the tumor stage, millimeters matter. 1 millimeters to 4 millimeters. It's a very small physical distance, but the survival rates for these different thicknesses of tumor are quite drastically. So again, sun protection to avoid mutagens. And then this graph here is just to show that there was a study that looked at sun exposure and the number of nevi, and the more sun exposure you have as a child, the more nevi you will have as an adult. And these are risk factors for developing melanoma. And another, thinking to the future, how else can we prevent melanoma? This is a child, these are pictures of children with congenital nevi. These are all precursor cells for melanoma. We can think about how can we reduce the burden of melanocytes in these children to reduce their risk of progressing to melanoma. And here's an example of a nevus here in the background in which melanoma has developed. So kind of keeping an eye on nevi and maybe reducing the overall number of benign cells that are at risk for progressing. So just to talk about how to detect melanoma, early detection and high-risk precursors, we have the ABCDs of melanoma, so asymmetry, irregular border, different coloration, the diameter is greater than the end of a pencil eraser. And I think this one is really important for patients, and that's evolution, because it's the easiest for patients to kind of track how their own pigmented lesions are evolving. And you can imagine, if you have a number of nevi, it can be challenging to monitor all of them and look for things that are evolving. Identifying patients at increased risk of melanoma for increased screening, for genetic testing, if there are 3 or more melanomas in an individual, especially if one occurs before age 45, 3 or more cases of melanoma or pancreatic cancer on one side of the family can indicate genetic predisposition to melanoma. And we're starting to learn more and more about different genes that contribute to melanoma predisposition. This is a melanoma affected family, so you can see that there's melanoma occurring at high frequency in this family. So we showed the picture of the patient with the multiple irregularly pigmented papules. BAP1 germline mutations also confer cancer risk. This is a alteration that was described about 10 years ago, and they have a distinct presentation. So oftentimes you'll have these small brown papules, and then within those you'll have these orange raised lesions that will develop. And if you get a biopsy, it will be quite distinct on biopsy. So your dermatopathologist might recognize, oh, this is a tumor with loss of this particular tumor suppressor. And then if you have multiple of these, or you have a clinical presentation that matches, maybe someone will suggest to you that you be screened for a germline alteration, meaning a mutation that's present in every cell of your body that is predisposing you to developing these specific melanocytic tumors or melanoma. And with that, I'll just leave you with, again, this is how we think about skin cancers developing, mutations accumulating in cells, progressing from benign to precancer to cancer, and then just avoiding mutagens and recognizing lesions early to prevent progression. Thank you.
Thank you very much, Dr. Ye, for very informative talk on genesis of skin cancers. Dr. Ye had touched on therapies that we do for pre-cancer and cancer topical therapies. So moving on was Dr. Kenneth Linden to come up and speak to us about topical therapies for skin cancer. Dr. Linden is a dermatologist at UC Irvine. He is co-leader of our melanoma program. So without further ado, I think Alice is loading up your slides. Just take about a minute or so.
Well, thank you all for attending today. I'm looking forward to telling you about topical therapy for melanoma and other skin cancers. And topical therapy is not something we think about so much when we talk about melanoma. As a dermatologist, dermato-oncologist, I think about it a lot for a lot of skin cancers. So let's just get into it here and learn about topical therapy for melanoma and other skin cancers. So can we use topical treatments for melanoma and other skin cancers? That's a big question. Let's see if we can. Let's see. So these are some of the topical agents used to treat skin cancer. We have imiquimod is one we're going to talk about quite a bit today in detail. It's FDA approved for treating superficial basal cell carcinoma, and it's actually a good first-line treatment for superficial type of basal cell carcinoma. There are about 5 different types. I think Dr. Ye, she did a really good introduction to skin cancers, and so that kind of made my job easier. But for the superficial type, it's FDA approved. It's good. We also use it for actinic keratoses. And we're going to see that it can be used for melanoma, but it's very specific uses and so forth for that. 5-fluorouracil, and imiquimod is also brand named Aldara. There's one brand name. 5-fluorouracil is brand name Efidex. I'm mentioning that because many of you as patients might be more familiar with the brand names. I'm going to talk about off-label treatments during this talk, and I have no conflict of interest in regard to this talk. It's FDA approved also for treating superficial basal cell carcinoma and actinic keratoses. These are the pre-cancers. They go on to form squamous cell if they're going to. They don't go on to form melanoma. Bleomycin, not commonly used. We use it for fairly rare kind of skin cancer called extramammary Paget disease. These are usually very superficial skin cancers of the groin area. And PDT, maybe some of you in this room have had PDT. It's a blue light therapy, we call it. So basically you paint on this chemical that's photoactive, and it's preferentially taken up by cancer cells or precancers. You give it time for the cells to take it up, and then you shine blue light on it. That activates the chemical and kills the cancer cells or precancer cells. We use that mainly for treating the precancers, but it's also used for treating these other kinds of skin cancers. DPCP, now that's basically a contact allergen. It actually stimulates the immune system. We're going to talk about that a bit more too. But it's not approved for treating melanoma, but we're going to talk about it being used for that. Liquid nitrogen, well, that's a topical treatment. I'm sure many of you in this room have had liquid nitrogen. The dermatologist comes in and sprays these precancers, these little rough scaly spots on your skin. And that's the most common way to treat that. It's not acting chemically, it's acting physically. That liquid nitrogen is cold. It's minus 195 degrees centigrade. That's minus like 300 plus degrees Fahrenheit. So it's really cold. And you spray it on there, it immediately freezes the cells that are growing abnormally and gets rid of them. That's a really great treatment. It's, like I say, the #1 treatment for precancers. It can also be used to treat basal cell and squamous cell, but we usually like to rather cut those out or treat them otherwise. It's occasionally used to treat melanoma in situ. It's kind of last line, I would say, for melanoma in situ, because it doesn't work that well. But if you basically have a very big cancer and you can't use surgery, you can't use radiation, you can't use imicomod, well, then you can consider treating it with liquid nitrogen. I've seen it done before, and it can be helpful, but it's, like I said, considered the last line. So let's talk a little bit more about imicomod or Aldara. It's a topical cream. We're talking about creams basically that you're putting on the skin today. And it's been studied to treat melanoma in situ. And we're going to talk, what is melanoma in situ exactly? Some of you know, certainly the physicians in here know, but we'll kind of go into that a little bit. So let's talk about imicomod to treat melanoma. So it is a cream that's applied. It's FDA approved to treat superficial basal cell, like we said, and actinic keratoses and warts. It's also FDA approved to treat warts of the skin because it stimulates the immune system to recognize all these things as something that doesn't belong on the skin and to get rid of that thing that's not belonging there. It's not FDA approved to treat any type of melanoma of the skin. Well, let's talk about it though to treat melanoma of the skin. And this is a specific type we can use it for is melanoma in situ. So studies have shown that a complete response rate from about 65 to 85% for treatment of melanoma in situ with imicomod. But for melanoma, which we consider to be a very serious kind of cancer, that's not very good, 65 to 85%. So we don't really want to use it as primary therapy. Primary therapy is the therapy you're going to go to first. So we don't want to do that. It's not on a par with surgical excision or superficial radiation therapy for treating melanoma in situ. But if the patient's not a candidate for surgical excision or radiation, then you can consider it, as third line therapy. And certainly it can be very useful in those cases because for various reasons, a person might not be a candidate for surgery or radiation. It's not effective for treating invasive melanoma of the skin. So only in situ, and like I say, in a second, we're going to talk about in situ a little bit more detail. Cure rate's just not high enough for invasive melanoma of the skin. So we're only talking about treating it in situ. This is a cartoon. It's not a great cartoon, but it shows the different stages of melanoma. This first one is in situ here at stage 0. We call that stage 0. And so on this cartoon, you have this first pink group here. And you're not really seeing, how do you get the pointer? Okay. Okay, thanks. Okay, so anyway, this first little layer of the skin is the epidermis. Dr. Ye showed you much better pictures of the skin in side view here. Actually, the epidermis is 2 paper sheets thick about on average in the skin. And the dermis is actually, this is even simplified, it's about 10 times as thick as the epidermis. So the epidermis is very thin. And this cartoon is not that great because actually it shows it just sitting on the surface, but actually the melanoma in situ basically is just right at the base of the epidermis. It kind of goes along here. And Dr. Ye did show you pictures of melanocytes sitting there at the base of the epidermis. And so in situ is great. When we see in situ melanoma, we consider it a success story because we know if we cut it out at that stage, it hasn't had a chance to get down here. You can see down here in the dermis, you have blood vessels and you have lymphatics. The blue is lymphatic. And when the melanoma gets down here, it comes in contact with those, well, melanoma cells can break off and travel through the blood or the lymph and go to the lymph nodes or other organs of the body, and that's bad news. Next is we have stage 1, which is invasive. So it's kind of gone a little bit past the epidermis here, just at the base. And so that's invasive melanoma. And again, we would not use topical therapies for invasive melanoma. Here it's stage 2, it's gone even deeper. And it's like 1 to 4 millimeters is going to be stage 2. Stage 3 is where it's gone so deep, it's actually gone into the lymph nodes. This is lymphatic, so you can see it's kind of invaded the lymphatics, and that's going to travel to the lymph nodes. So that's when surgical oncology and the medical oncology come into play. And stage 4 is where it's basically gone through the blood into other organs like the liver, lungs, and brain, and so forth. But we're interested in situ, which is basically up here. So let's look at the next slide. And this is not a pretty picture as Dr. Ye showed, because she's a dermatopathologist and she can take her own pictures. But this shows the epidermis, and the dermis is down here, this paler area down here. But this upper part is the higher magnification of the epidermis. And you can see each one of these are individual skin cells. And again, the total distance from this to this is only about 2 paper sheets. So this is highly magnified. But this shows melanoma in situ, and all these pigment cells down here, there should not be that many. When she showed the melanocytes, you didn't see them like this. Shows you why melanomas are black, because they produce all this pigment, and you see all this, they're just sitting down here very disorganized. They kind of move up into the epidermis, further up, all the way up to the top of the epidermis. So this is melanoma in situ, and it hasn't gone down past the epidermis. It hasn't been able to get to the blood vessels or lymphatics. So like I say, if we can cut it out and get it at this stage, we consider it success. Okay, this gentleman has this, let's look at it clinically. This is melanoma in situ on the nose. You might think, Jesus, it just looks like a sunspot, but it has some other features that dermatologists would definitely say, oh, we need to biopsy this, because it's got some very dark areas, black areas, essentially, and the pigment is not very symmetrically organized. It's a big lesion, and he doesn't have anything like this elsewhere on his face. So this is a sun-caused type of melanoma called lentigo maligna. And it definitely is what we're going to talk about as far as could be amenable to partially treating with topical therapy. Okay, this is another lesion here. This is an 83-year-old woman who was referred to me for something on the ear. The thing on the ear was just a benign seborrheic keratosis. So the physician who referred it thought maybe it could be melanoma, but it wasn't. But then on doing the exam, I saw this thing on her wrist, and again, it kind of stands out. It's a little darker than all the other stuff on her skin, a little bit bigger. And when we look at it closely, different views of it, it has some features which you can't see that well here, but with the dermatoscope that we use in clinic, it's got some dots and globules in there that make us concerned for melanoma. And so I biopsied it. And indeed, it was melanoma. So this one's a little bit invasive. It's 0.3 millimeters. So we wouldn't treat it with a topical therapy first up. So we want to cut it out. This is my planned excision here. And for melanoma, you want to take a good margin. So this is a 1 centimeter margin. It's invasive. That would be standard. Cut this out. And this is my planned excision. So I'd cut it out like this with a 1 centimeter margin. And then we cut up here and cut down there. And then this skin is all going to be undermined. We're going to move it towards the center. We're going to move this towards the center to close this big hole we make. And you can see this is on the wrist, but if it was on your face by your eye, that's going to be problematic, right? I mean, how are you going to cut that out with that big margin, for one thing? And two, how are you going to close it? You have all those big lines you're going to have to move the skin around to do. So that makes it hard. And so we'd like to take a smaller margin on something like this. We're going to talk about what techniques that can allow us to take a smaller margin so we don't have to make such a big hole in a person, particularly on the face. It's okay here because the skin is lax enough that we can do it. Now, next slide, I'm going to show a picture of where I cut it out. So if you're a kind of person who doesn't like to look at wounds, you best maybe not look at the next slide, couple slides, 2 slides. Anyway, this is the wound that I made when I cut it out. You say, Dr. Linden, that's a lot bigger than this. Well, actually, I did cut it out the size I showed there. But when you cut out something, the skin tension will just kind of pull it open. It kind of gapes. So that's how the skin is gaping there. Here's a close-up, a lot of neat anatomy down there. But the good news about when we cut out melanomas, if they're thin like that, all you do is cut out skin and fat, and you leave everything intact beneath. So there's a lot of important structures in your wrist right there that you don't want to damage, and we didn't. So I did close it. Like I said, I undermined it, cut up all the skin up here, undermined it, all down there. Push the skin to close the hole that way, that skin to close the hole that way. It's called an O to S closure. Here it is 2 weeks after suture removal, healing like a champ. Here it is again, another picture of that 6 months after excision repair. So that melanoma never came back. So that's how we like to treat melanoma. cut it out. That's the number one treatment for it. Particularly the thinner melanomas, a chance to cut is a chance to cure, we like to say. And that's definitely the case for melanoma. Okay, but this again is on the face. And this kind of shows, and this is also a lentigo malignant type of melanoma. This is sun-caused melanoma. Dr. Ye said it's important to protect yourself from the sun because you don't want to get these sun-caused melanomas. Anyway, this one shows another kind of some problematic features here. So here we have the melanoma, but you can see it's really hard to distinguish. Well, where's the margin on this? Like it's kind of dribbling out with pigment over here. And it's kind of dribbling the pigment out here. And you have pigment up here, here, over here. So where are you going to cut your margins? You know, even if you take a narrow margin. So this can be very difficult to determine the margins of where to cut. You could treat this with radiation. Like I say, we'd prefer cutting. It's got a higher cure rate, but you could treat it with radiation. That'd be a quite reasonable option to treat this. But you have to choose some margin, and you could either just cut it out and see if you got it all out, or you can do Mohs surgery. Some of you in this room, I'm sure, have had Mohs surgery. I know you've had Mohs surgery, some of you, because some of you are my patients. Anyway, that's kind of where you look at it on the microscope right then to see if you got it all out. And that's a good technique. It's really hard for melanoma because it's hard to read melanoma under frozen sections. Dr. Ye was saying how hard it can be just even with permanent sections, and you're an expert like her. Well, if I'm a derm surgeon, I'm trying to read it. It's also very hard. So we want something to help us out. And that's where maybe topical therapy can help us out. And we'll see about that in a minute. And here's another lentigo malignant type of melanoma in situ. Again, this is huge. And it kind of dribbles out down here. And so you have to figure out, okay, what margin am I going to take? And am I going to get it all? And you could cut this out. You know, you can have to move the neck skin all the way up, you know, like that. It'd have to be done in the OR for sure. But it could be done, but also radiation would be a good treatment for this type of melanoma in situ. So in situ is just in the upper layer of the skin, and it will respond to radiation. We don't like to treat invasive melanoma with radiation at all because, again, invasive is just not quite there. When it's sitting on the surface of the skin, it's pretty amenable to radiation. When it's only in the layer that's 2 paper sheets thick. Now we talked about lentigo malignant, the sun-caused melanoma. This is another type of melanoma that can be in situ, which means it's in the upper layer of the skin. But the superficial spreading type is more well-defined as far as borders. So if this was on your back, you could feel confident if I took this out with 5 millimeter margins or 1 centimeter margins, which would be standard for melanoma, that we would highly likely to achieve clearance. So we wouldn't use topical therapy in something that this is well defined, and we could take a good margin on and be very confident in our margins. So we're still getting to treating it with topical. We're getting there. So anyway, by now you're all probably thinking, geez, I've got a bunch of melanomas on my skin, but you don't. So not everything that's pigmented is melanoma. This shows just a sunspot, basically a solar lentigo, another sunspot. These are benign. We see that most people have these. And these are seborrheic keratoses. Again, dermatologists looking at this would not look twice at these. And you start getting these in middle age, almost everyone starts getting them, and you get just more as time goes by. As decades go by, the more you get. So not everything is pigmented melanoma. So now let's get back to actually talking about treating these with topical therapies. So imiquimod does not have an adequate cure rate to treat as primary agent, we said, but it can be used to improve the cure rate after surgical excision. So treating with an additional therapy after primary therapy has been performed is termed adjuvant therapy. And you're going to hear about neoadjuvant therapy in a coming talk today, but adjuvant therapy is after you try to treat it primarily. So if you cut it out and you want to do something afterwards, like radiation afterwards, or treat it with topical medicine, that's called adjuvant therapy because it helps you increase the cure rate of the primary treatment that you used. So using imiquimod around the excision site after an excision of melanoma is a form of adjuvant therapy. Adjuvant therapy of melanoma isn't used in a location where wide margins can be taken. Like I said, if you can be very confident in your margins, the margins are all clear, then you're not going to use imiquimod as a mop-up. But if it's on the face, you want to take narrow margins, you're doing something like Mohs surgery, which is really hard to read the slides to make sure you get it all out, then you want to consider something like imiquimod around the edges of it to increase your cure rate. And I do this all the time. I just cut out a melanoma in situ of a person's neck on Thursday, 2 days ago, and I'm going to let it heal up. We let it heal up for about a month, and then he's going to start applying imiquimod to the edges of the wound daily for 8 to 12 weeks, adjusting for tolerance. You have to adjust it back from daily because almost everyone would get very raw if they used it every day for a whole 8 weeks or something. So you basically cut back until it's just red but not raw. And that's what he's going to be doing starting about a month from now. And it will increase his cure rate. So let's talk a little bit about the future here. We're going to talk about topical immunotherapy. So we talked about imiquimod, that is a topical immunotherapy. Now let's talk about DPCP. Now this is for treating melanoma cutaneous metastasis. So this is a different type of melanoma. This is melanoma that's already spread to other parts of the body, and it's one of those parts of the body it can spread to is back to the skin. And that can be very troublesome. It can be functionally debilitating and cosmetically devastating. So we need treatments for this form of melanoma that's spread this way on the skin. So this is a gentleman. This is out of the journal. This is melanoma. And you can say, Dr. Linden, why did you let it get that bad? Well, he didn't let it get that bad. He had a small melanoma that was deep. And so that was cut out, but then it had already spread to other parts of the body. And one of the places it came back to is to the skin. So just like it can spread to the lungs, liver, it can come back to the skin. All this is very troublesome. So what they decided to do, you could radiate this whole area here, but that's a huge field of radiation. He's going to lose all his hair too. So what they did in this article is they used DPCP, which is like Aldara and imiquimod. It's a topical agent. They put it on there, and look at this is sometime some weeks to months later, and you can see the melanoma is basically melting away. That's amazing. And a lot of this is probably just dead melanoma cells, because even if you biopsy this, probably wouldn't show any live melanoma cells. It would just show pigment that was just being gradually eliminated. So you can have success stories with topical things like DPCP. This is another case. You can see the surgical scar up here. So this was cut out, looks like a couple of years ago. And usually within a couple of years, if it's going to do it, it's going to do this, where you can see all these little dots, like ink dots here. These are all little metastasis of melanoma, where the melanoma has sent out little seeds out into the lymphatics here. And it's bad news. How are you going to, you can't cut out all this stuff. So you're going to either have to treat it with radiation or something else. Well, they use DPCP. And you can see this immune stimulating agent. It stimulates the immune system. You get this nice ripping reaction, just like you can to imiquimod. But look, all these things have melted away. So that's amazing. Okay. Now, this case was, I'm going to be wrapping up here pretty soon. This case was one in our Journal American Academy of Dermatology, one of the two main derm journals. And it's a letter, and they report this patient had a bad melanoma. It was deeper than 2 millimeters to begin with. So unfortunately, it did spread, as it's highly likely to, and it spread to his lymph nodes and lungs. And he got 4 cycles of dacarbazine. For the oncologist in the room, that's going to bring back some nostalgia, because we don't use dacarbazine much anymore. And probably not good nostalgia, because it wasn't that effective back then. It was only about a 6% maybe complete cure rate or something, complete remission rate with it. So it's not a great therapy. Now they have all these wonder drugs, but that didn't work. It didn't solve the problem. And the lung lesions and the lymph node lesions progressed. And they started giving DPCP to the skin lesions just to try and palliate it, to make those better, because they were getting worse and worse and worse on the skin. And they did that, and they got some improvement with the skin. But then they basically they stopped that. But then about a month later, all these skin lesions and the lung lesions and the lymph node lesions started melting away. And he got into complete remission. He was in complete remission for 18 months at the time of this publication. So the DPCP, they postulate, stimulated the immune system, just like we have all these nice immune checkpoint inhibitors now, which I'm probably aware of or you'll hear about. And so it was working from the outside to stimulate the immune system, rather than like the immune checkpoint inhibitors that we use now, where they're infused or taken by pill and so forth. So this is a great case and very exciting. So in summary, I've basically talked about topical agents that are FDA approved to treat skin cancer. And there are not that many that are FDA approved, like say imiquimod, 5-fluorouracil. We use a lot of agents off-label. Imiquimod, you can use it as adjuvant treatment for melanoma in situ after it's cut out. DPCP can be used to treat cutaneous metastases. And basically, in conclusion, I want to say that topical agents are FDA approved to treat certain forms of skin cancer, and they can be useful off-label for treatments of some types of melanoma under certain circumstances. And so the keys are there, some types like in situ or melanoma metastases under certain circumstances. And usually it's not a first-line treatment for melanoma in any case. And I predict in the future that topical therapies will be more widely used in conjunction with immune checkpoint inhibitor therapies in treatment of melanoma and other cancers. There are people doing that now where the oncologists are working from the inside with the immune checkpoint inhibitors, and that's stimulating your immune system from the inside. And then if you put something like DPCP or Aldara on the outside, you're getting a double whammy. And some people are doing that and showing increased response rates. And so obviously we want to continue to do that. And so I think you're going to see more of this. I think it's an untapped area. So I think there's some excitement there. Lastly, Dr. Chao talked about our anti-cancer challenge. Here's our melanoma team at UCI. We're the melanoma magicians, and we're the melanoma magicians because we are making melanoma disappear. And so you're welcome to come and join us on October 11th. I'll be running. These are our walking contingent here. I always like to run it, but this is our whole team here. Thank you very much for listening to.
Thank you very much, Dr. Linden, for that fascinating talk and those pictures that you showed of the surgery. I guarantee you I will not be running in the anti-cancer challenge. I am always a walker. So moving on, we have Dr. Thuy Tran. She is an assistant professor of surgery at the University of California, Irvine. She is my melanoma surgical partner, along with Dr. Maki Yamamoto, who's in the audience here. And Dr. Tran will be speaking on oncolytic viral therapy for melanoma.
Thank you. Good morning, everyone. And a couple of years ago, I think I talked about surgery, sentinel lymph node biopsies. So I kind of want to switch it up a little bit this year and talk about oncolytic viruses and how it's used to attack and destroy melanoma. So about me, I am a surgical oncologist at UC Irvine. I'm a melanoma surgeon. I also do other rare skin cancers like Merkel cell carcinoma, the really bad, difficult, like the types of basal cell and squamous cells that your dermatologist sends to me because they got too big to be resected, in the office, and other rare soft tissue tumors. I personally hate cancer, and I absolutely always, and I hate melanoma. So the skin, believe it or not, the skin covering our body is our first line of immune defense. It acts as a natural barrier, and when everything is working well, the immune system is active in our skin. And again, surprisingly, no one thinks about it. It is part of our immune system. And here you see in this figure, there are a lot of different types of immune cells on our skin. However, skin cancer can develop when the tumor cells have gained the ability to shut down the immune system response. And when the immune system is not working well, it doesn't kill the cancer cells, and then melanoma develops. So let's talk about immunotherapy. So cancer, as many of us know, is very sneaky, especially melanoma. And melanoma manages, and when you get melanoma, that means that it managed to evade our immune system. And the way it does that by displaying these like molecules on the surface, so when your immune system is out there patrolling, it doesn't recognize the melanoma cells. And Dr. Vidya is going to talk more about immunotherapy in more detail, but I kind of just want to briefly, talk about it. And oftentimes the surgeon is the first person who talks about immunotherapy. When I see a patient in clinic, I talk about immunotherapy. They always ask me, Dr. Tran, is this chemotherapy? I tell my patients, this is not chemotherapy. You are not going to lose your hair. Chemotherapy is a type of drug that kills both healthy cells and cancer cells. it's a cytotoxic drug that has many side effects. Immunotherapy, on the other hand, what I tell my patient is actually supercharges your immune system. It supercharges your immune system to actually recognize the melanoma and start attacking those melanoma cells. And because it's very specific, it selectively attacks melanoma cells, you don't have this kind of side effects that you tend to see in like immunotherapy. It actually tends to be fewer side effects, and side effects tend to be more autoimmune. So there are different types of drugs that we have available to treat melanoma. We have the medical oncologists who give the oral therapy, intravenous therapy, as well as sometimes interlesional therapy. Here at UCI, the surgeons actually do the interlesional therapy, and that's what I'm going to talk about today. We do have a type of interlesional therapy that we use to directly inject the drug into the tumor to fight melanoma. So what is oncolytic viral therapy? So it's different from checkpoint inhibitors, but still classified as an immunotherapy. So oncolytic viral therapy is a genetically modified treatment that uses a human virus that has been genetically modified in the lab to target and infect cancer cells. So it infects cancer cells but leaves normal cells alone. It's also modified in a way that actually stimulates an immune response, meaning when it infects a cancer cell and that infected cancer cell opens and releases its content, immune cells are actually alerted, and it promotes a systemic activation of the immune system, amplifying that systemic anti-tumor effect and killing other areas where the tumor exists. So essentially actually re-energizes the body to attack the cancer using its immune system. So currently the TVEC is a FDA-approved oncolytic viral therapy that is being used. It was approved in 2015 for the treatment of unresectable or recurrent melanoma. Again, this is an intralesional therapy, meaning that the drug is directly injected into the tumor. As you can see in this figure, this is a patient with melanoma involving like the extremity of the upper arm, and just like a large area here, too large to be resected. So this person is getting the oncolytic therapy injected directly into the tumor. So just a little bit of a science behind then how we got to this point. So this was a phase 2 study that was published in 2009. It looked at 50 patients with unresectable stage 3 and stage 4 melanoma treated with intralesional oncolytic therapy. They got injections up to 4 milliliters. And they found that the overall response rate was about 26%. 8 patients had a complete response and 5 patients had a partial response. And the response tend to be fairly durable, with 92% of responses being maintained between 7 to 31 months. And the overall survival at 1 year is 58% and 52% at 2 years. Okay, and the nice thing that the exact study actually showed a couple of examples where the response can extend beyond the area that was injected. So in this patient who had metastatic melanoma involving, there was some soft tissue deposit in the posterior shoulder and back, as well as in the abdominal lymph nodes called retroperitoneal lymph nodes, and also the lung. So this patient who had metastatic melanoma, he had injection of the oncolytic therapy in the left posterior shoulder. About 2 to 3 months later, the subcutaneous mass in his shoulder started to disappear. And at 8 months, as you can see in this figure, the lymph nodes in the abdomen, retroperitoneal lymph nodes, start to disappear, as well as the lung nodule has also disappeared. So even though those sites were not injected, you can actually see a response that extend beyond the area that was injected. In a similar fashion, this is a different patient. This is another patient with metastatic melanoma involving the axilla. Also had metastasis to the pancreas. So you can see in the pancreas, this little area in the pancreas lit up. So the axilla was injected with this oncolytic, viral therapy. And a few months later, I think about 5 to 6 months later, with a repeat scan, the mass in the axilla definitely substantially decreased, and that pancreatic, mass also disappeared on the PET scan as well. So this eventually led to the approval of this drug in 2015. So there was a phase 3 study that randomized about 436 patients treated with TVEC as well as in the control and compared to GM-CSF for unresectable recurrent stage 3 and stage 4 melanoma. We found that the durable response rate was higher in the TVEC group, about 16.3% in TVEC compared to 2.1% the control group. The overall response rate was higher in the TVEC group, 26.4% compared to 5.7% in the control group. And the overall survival was higher in the TVEC group, 23.3% versus 18.9%. So again, as in any kind of treatment, there are side effects, and most of the side effects tend to be more related to, viral related, because again, this is a genetically modified, virus. And I tell my patients, you might get a bad flu. So it tends to be like fever, chills, fatigue, and that usually, goes away in about, 2 to 3 days. I tell my patients take Tylenol, drink fluids, and we keep an eye on them. But for the most part, I tell my patients it could be a bad flu if you do get side effects. So a couple interesting cases, we're all visual creatures. So this is one of my dear patients. Really sweet, gentleman. He, a couple years ago, back in he had a 1.25 millimeter right scalp melanoma. It was not ulcerated. He had surgery, had a wide local excision, sent to lymph node biopsy. Margins were clear. Lymph nodes were, negative. So we're undergoing surveillance. 7 months later, during a routine check, he developed these black, you see these black, nodules in the scalp and this pigmented area that wasn't there before. So of course we did a biopsy, it did confirm he had recurrent melanoma. So we started on IV immunotherapy. And again, like some patients do great with immunotherapy, some patients, get side effects. Unfortunately, this patient, when he started immunotherapy, had some side effects. So he had to stop it. And even while on immunotherapy, he, continued to have progression. You can see his whole scalp, had these all these melanoma deposit. And as a surgeon, I can do surgery, but I'm not going to take out his whole scalp. That's just not nice. So at this point, I started this patient on TVEC. Okay, so I started him on TVEC, and after a couple cycles of TVEC, this is his scalp. Oh, not too bad. So at this point, I also did some biopsies just to be sure, and he has no evidence of recurrence and remained disease-free at this time. Here's another example of another patient with history of melanoma with the back. Obviously a very extensive disease. We started on immunotherapy. It looked like he did have some response, and a lot of spots have decreased in size. But some patients, despite having response with IV immunotherapy, can develop, resistance, and then new spots start to develop. So then this patient was actually given both IV immunotherapy and TVEC, and that can have a synergistic effect. A few months later, as you can see here, those lumps that you can see have actually started to almost completely, essentially disappear. So this demonstrates the synergistic effects of using both intralesional oncolytic viral therapy and IV immunotherapy to fight melanoma. So you can imagine we've gone a very long way with melanoma, with so many different drugs, IV, oral, and even intralesional oncolytic therapy. But there is work that we have to do. We still have a problem that not all patients respond to these therapies. Some patients are resistant to immunotherapy. It is a great drug, and some patients are resistant. There are some patients who have a response and acquire resistance to immunotherapy. So there's a lot of active research, both in the clinical side as well as a basic science, realm that is trying to answer this question to improve patient care. So there's been 2 recent intralesional oncolytic viral therapy clinical trials. The first one was recently closed, but this was actually a neoadjuvant trial, looking at patients with resectable melanoma. This looks like look at interlesional therapy called CMP-001 in combination with IV immunotherapy in patients who had resectable melanoma. And this is one example of one of my patients in the study. He had a history of a melanoma on the right arm, developed a recurrent subcutaneous mass in the right upper arm. He underwent this clinical trial, got the oncolytic viral therapy as well as IV pembrolizumab. And then a few months later, we did surgery, complete response. There was no evidence of residual tumor that I removed. So that just shows that the combination of both oncolytic viral therapy as well as surgery and IV immunotherapy can actually can truly help patients in this setting. And there's one ongoing interlesional oncolytic viral therapy right now that is enrolling patients. And this is actually for unresectable patients who have progressed on IV immunotherapy. This is a phase 3 study looking at oncolytic therapy called RP1 in combination with immunotherapy. And the nice thing about this new trial is compared to TVEC, which I only have 4 ml, which is not that much. This drug actually gives me 10 ml. And the difference here is, TVEC, I usually inject in the skin, the lymph nodes, but I can actually, I can visualize with ultrasound, what have you. The nice thing about this clinical trial is that we can actually inject in the lung, we can inject in the liver. And I think the phase 2 results have been very promising and are currently enrolling in the US and will open the trial soon in Europe. Thank you for your time.
Thank you, Dr. Tran, for that interesting pictures you showed of patients responding to oncolytic therapy. So it's obviously very promising. So next is my colleague, Dr. Purva Vaidya. She's an assistant professor in division of hematology oncology, so medical oncologist, and my new partner in medical oncology. So
Thank you.
she'll be she'll be speaking to us on neoadjuvant immunotherapy, preoperative immunotherapy.
Good morning, everyone, and thank you, Dr. Chao. So today I'll be talking to you about neoadjuvant immunotherapy. This topic we could probably talk about it all day, and there have been talks about it in symposiums past, but it's particularly interesting this year because we've had 2 big clinical trials published in 2023 and 2024 that have really made this treatment approach more common. So I'm going to go through and define neoadjuvant immunotherapy for you, talk about the history of melanoma and immunotherapy in general, talk about our rationale for neoadjuvant immunotherapy, cover the 2 big trials, and then talk about some future directions and exciting research initiatives on our end. So what is neoadjuvant therapy? It's a general term. It refers to preoperative treatment, so medication given before surgery. It can apply to chemotherapy, it can apply to immunotherapy, and it differs from adjuvant treatment, which I think we mentioned earlier today. This is post-operative treatment that's given after a tumor has been removed. And historically, we've used neoadjuvant chemotherapy in other tumor types, particularly breast cancer. And the rationale there was giving chemotherapy before a surgery could make the tumor smaller and lead to a less invasive surgery. But immunotherapy or neoadjuvant immunotherapy, and particularly in melanoma, it's a little bit different and the rationale is a little different. So I will try to explain that. And to do that, we have to rewind to 2011 when we started getting approvals for immunotherapy in melanoma. As it's also been mentioned today, historically, melanoma does not respond well to chemotherapy. We had pretty dismal outcomes in metastatic disease back in the 90s and early 2000s. And with the advent of these immunotherapies, we've had people live longer, and we've been able to confer no evidence of disease and have patients not progress for years. And these drugs are drugs you may have all heard of. So ipilimumab, the brand name for that is Yervoy, or ipilimumab and nivolumab, which is Yervoy Opdivo, pembrolizumab, that's Keytruda, and then most recently nivolumab and relatlimab, which is Opdualag. But despite making all of these advances in metastatic melanoma, we know that there's a subset of earlier stage melanomas, like stage 3 melanomas, that are high risk for recurrence, meaning you can take it out and there might be some micrometastatic disease or cells hiding in the bushes, if you will. And these aren't things we can detect by looking at an image or on your exam, but they might be floating in your body, and over time, they can develop into metastatic disease. And I don't want this to be misleading, this image. The figure is undergoing surgery, and that's not the tumor spreading after surgery or anything. That's just probably disease that was there. And we want to develop ways to prevent melanoma from spreading and becoming metastatic over time. And that's where adjuvant therapy comes in. There were approvals in maybe 5 or 6 years ago, starting 2017, to reduce the risk of recurrence by giving adjuvant therapy. So the premise here would be you would do surgery and then you would target that micrometastatic disease by giving 1 year of a treatment after that. And so, as I mentioned, we've had concurrent approvals for that setting. Specifically, the Checkmate 238 trial approved Opdivo or nivolumab for this indication, and then the Keynote 054 trial approved pembrolizumab or Keytruda. There have also been some approvals in the stage 2 setting, but that's a little bit outside of our scope, so I won't go into it. But despite conferring advantages in what we call recurrence-free survival, meaning reducing the risk of it coming back, we haven't yet shown that patients are living longer. We haven't seen an overall survival. And so there still remains the question of how can we optimize these therapies to give a bigger advantage. And I actually really like Dr. Tran's image of how immunotherapy works, but this is the image I have, and we can talk about this for hours, but I'll briefly go over how immunotherapy works. And it all lies in your immune system's ability to detect a melanoma tumor as self or foreign. And because tumors have these mechanisms that can help evade the immune system, they can grow and evolve. And what immunotherapy does is it kind of interferes there and allows the immune system to detect the tumor as a foreign entity and then launch an appropriate immune response to fight it. So it's not like chemotherapy in the sense that it doesn't go in there and just kill all the good cells and bad cells, but it leverages your own immune system to fight the cancer. And so the idea behind giving immunotherapy before surgery in a neoadjuvant fashion is to leverage that. So if we give immunotherapy while the bulk of the tumor is in place and in the body, we're providing a larger blueprint or bulk of the tumor for an appropriate immune system to launch. And so then when the surgeons, Dr. Tran and Dr. Yamamoto, my colleagues, they go in and they take out the tumor, we still have those activated diverse T cells that have that memory and can exert a response that's sustained in a patient's body. And so this is kind of the paradigm shift that we're seeing, that we will identify a tumor, and these are stage 3 tumors, so tumors that we can see have already spread to the lymph nodes, and we can give immunotherapy and then do the surgery, but now we already have that immune response that's launched in the body, and it can continue to exert an effect. And so it's more than neoadjuvant chemotherapy that I mentioned earlier, because the purpose is twofold. It will leverage the immune system to have a more robust and sustained immune response, and it can also reduce the size of a tumor prior to surgery. And as I mentioned, we've had 2 big trials come out, the SWOG S1801 trial and the NADINA trial, which have given us the best evidence thus far of this treatment approach. Both of these trials were published in the New England Journal of Medicine in 2023 and 2024. So I'll first go over the SWOG S1801 trial, and this was a phase 2 trial that enrolled 313 patients with clinically detectable stage 3 disease. So to clarify again, these are patients where we have exam or radiographic evidence that the melanoma, biopsy confirmed melanoma has spread to a lymph node. This is not the group of patients where you've taken out the tumor and done a sentinel lymph node biopsy that's shown a tiny drop of melanoma in a tumor. We can easily visualize this. And half of these patients received standard of care treatment in which they underwent surgery and then received 18 cycles or about a year of Keytruda afterwards. And the other half of patients, they received 3 cycles of the Keytruda before surgery. Then they received their surgery and then they continued treatment after. And the researchers measured something called event-free survival as their primary endpoint. So event-free survival means surviving without the disease coming back, the disease progressing before surgery, dying of any cause, or having a toxic effect that precludes the surgery. And the results were quite striking. So at the 2-year mark, the event-free survival in the neoadjuvant adjuvant group, so patients who got it before surgery, was 72% versus 49% in the group that only got it after surgery. And that's reflected in the curves here. So that blue line is the patients who got the surgery or the treatment before surgery, and they had better outcomes than the ones who only got it after surgery. And then this other chart here shows that the tumor size decreasing. So the group over here, closer or right here on the objective response, where it says these are the patients who had a decrease in the size of their tumor, and then the other half is the ones who stayed stable or got bigger. And this doesn't necessarily correlate exactly with the outcomes we're seeing at the 2-year mark. So that kind of tells you that it's not only about shrinking the tumor, but about having that immune response. And so the NADINA trial was similar, but designed in a little bit more of a complicated way. So this is a phase 3 trial. It enrolled 412 patients, again, with clinically detectable stage 3 melanoma. Half of them got standard of care treatment in which they underwent surgery and then got 1 year of nivolumab, which is Opdivo. And the other group, the experimental arm, they got 2 cycles of Yervoy Opdivo, and then they got surgery. And then what was different and unique about this trial is that the treatment after surgery was very much tailored to 2 things. One, did the patient have a good response? That means if there was no evidence of tumor or very little tumor, what we call a complete response or a major pathologic response, these patients were just observed. They underwent no further therapy for the year after their surgery. However, if these patients only had a partial response or a non-response, then it depended on their BRAF mutation status. This is a mutation that half of melanoma patients harbor. And if they had the mutation, they got targeted treatment. And without any mutation, there was the 1 year of Opdivo as we've been getting for a standard of care before. So again, they measured event-free survival as their primary endpoint. And their results were also quite striking at the 1 year mark. There was an event-free survival of 83.7% in the neoadjuvant combination group and 57.2% in the adjuvant group. And that's again reflected by the blue line is the neoadjuvant Yervoy Opdivo group, and the red line are those patients who got surgery first and then the adjuvant therapy. So again, the patients who are doing well at the 1 year mark, it's substantially higher with the neoadjuvant treatment. And so which one do we use? Is it better for a patient to get the Keytruda per SWOG S1801 or NADINA with Yervoy Opdivo? And really this is a conversation between your melanoma team, which will be your medical oncologist and your surgeon. But there are a few differences between the two that I'd like to go over. One is that with the Keytruda group, there was a 21% pathologic complete response, meaning we didn't see the tumor at the time of surgery, whereas with the Nadina, the Yervoy, Yervoy Opdivo, 47.2% complete response. And then everybody asks, why would I wait to get my surgery if that's going to cure me? What if I start getting this immunotherapy and my tumor progresses? And what the trials found was that with Keytruda, there was a 9% progression rate, and with Nadina, 2%. So different numbers, but still pretty good. And I think the biggest thing when we're choosing comes down to toxicity. So Dr. Tran mentioned that, the side effects of immunotherapy are much different than chemotherapy, but as many people in this room may be familiar with, they can be quite significant. You can get immune-mediated side effects, which means there's collateral damage of activating your immune system that can attack other parts of your body. And that is more prevalent with the Ipi-Nivo. So the grade 3 toxicity, which is what we refer to when we talk about significant side effects, it was up to about 30% in the Nadina trial with the Ipi-Nivo and 12% in the single agent Keytruda group. There's some differences in how we administer them too. The Keytruda is for 3 cycles. So you get it for about 9 weeks before your surgery, whereas with the Ipi-Nivo or the Yervoy Opdivo, you get it for 6 weeks. It's 2 doses every 3 weeks. And then the adjuvant schedule, the post-operative schedule, of course, differs. Everyone who gets the Keytruda before and after surgery. But with the Nadina trial, it's possible to not do that post-operative therapy. Although I know a lot of us are still wondering if we need longer-term outcomes to really make that decision. And then one of the trials actually did involve patients, SWOG 1801, some patients who had stage 4 disease, so more spread out melanoma, but you could take it out. So it's all very exciting, but there are a lot of future directions and a lot of questions that we still have. One, we want to identify prognostic biomarkers. These are things that we can detect in the blood or in tumors to decide who does respond to treatment and who is the best candidate for this treatment approach and who's going to progress or have downstream poor outcomes. We want to optimize the number of neoadjuvant treatments we give and really define whether it's okay to tailor treatments in that post-operative setting. We have yet to establish the survival benefit and really know if people are living longer. And lastly, we're exploring something called the role of therapeutic lymph node dissection. And this is kind of what, this is a trial schema from an older proof of concept study in which called the Prado trial, in which patients with stage 3B and C melanoma received neoadjuvant Yervoy Opdivo. And then the researchers just tested a pre-identified and marked lymph node with the largest metastases. And if there was no evidence of significant disease there, they decided to not undergo the more intensive surgery of taking out all their lymph nodes. And they found that on a 2-year scale, these patients still had a really good recurrence-free outcome, upward of 90%. So that's where we're excited here at UCI to focus our next set of research efforts. And with that, I'll end. Thank you all for listening. And I'd like to thank all of my colleagues here.
Well, thank you very much, Dr. Vadia, for that great talk on neoadjuvant immunotherapy, kind of our new paradigm shift here. So at this point in time, we have a question and answer session for our morning speakers. And so I'll ask that our morning speakers come on up. If you don't mind bringing up a chair with you so that we can all be a little comfortable here.
If there are questions in the room, you can write them down on the pads that were provided, and we'll get those to Dr. Chao.
So, I'll kind of moderate this, session here. So we already have quite a few questions, from, our live audience here. So the first, question is, I've had 7 stage 1 cutaneous melanomas. I think I will have more. Would I benefit from immunotherapy to prevent more? So maybe I can ask Dr. Vadia, our medical oncologist, and then perhaps Dr. Linden can follow.
So we're not, there's no approval yet for preventative neoadjuvant immunotherapy without an established diagnosis and a stage 3. So, and I don't know if I heard the first part of the question, but I think it's all resected. There's no like stage 2 or. Yeah,
believe
so
that's right.
if there was a higher stage melanoma, then we could do the year of adjuvant therapy.
Dr. Linden.
Yeah, well, if you've had how many of the person?
7.
7. Well, I'd say the good news is that you're catching them early. You know, they're all stage 1. So between you and whoever your doctor is who's detecting them with you, your family, if your wife or husband is detecting them, that's great. You're catching them early. In general, we don't have great treatments for pre-melanoma like things on the skin. When I was talking about topical therapies, we use those for actinic keratoses. Actinic keratoses are pre-squamous cells though. So if you're saying I've had 7 squamous cells, I'd say, yeah, we should try be treating you with 5 or Uracil topically, on the area where you're getting all these skin cancers. Don't really have any evidence that it's going to work putting it on general areas of the body for melanoma. So I think the best thing you can do is keep up the good work in that you want to be surveilling yourself very frequently, like every month. You should be looking at your whole skin. You should be going into your dermatologist or your surgical oncologist, whoever's following you, to do full skin checks very frequently. I'd say every 2 to 3 months, you should be going in there. And you've had 7 melanomas, you also worry about, okay, do I have a gene that predisposes me for melanoma? You have family members that also have melanoma. And, if you have brothers or sisters, parents, basically all first-degree relatives, you want to make sure that they're being checked regularly also, because as Dr. Ye talked about, preventing melanomas, part of prevention is secondary prevention, where you're preventing them from getting out of hand, like you're doing excellently. So you're getting them so early. And so, like I say, just surveillance is very important for you.
Okay, would you like to add anything on about the genetics?
Yeah, I think with 7 primary melanomas, you should consider genetic testing for predisposition, and that can be helpful for children, other family members.
Dr. Tran, question is, what stage melanoma is appropriate for oncolytic therapy?
Yes, so currently is FDA approved for unresectable stage 3, stage 4 melanoma. Also for recurrent melanoma that's not amenable to surgery. There are clinical trials looking at resectable melanoma. You can get like oncolytic therapy before surgery, but that's, currently in a clinical trial basis.
To Dr. Vadia, which side effects are most likely to dissipate over time? Which ones will need to be treated long-term? I assume this regarding immunotherapy.
So if there's a mild rash or something that can typically resolve over time, and we can treat it with topical things depending on the severity, sometimes oral steroids. Other things like colitis can also resolve, but if you get an endocrinopathy, which is like if your hormones are affected, or if you get a more serious side effect, like a pneumonitis or anything, we're a little bit more hesitant to re-challenge, and some of those side effects can be more permanent.
Another question is, I was successfully treated with Opdivo for stage 4. I am 36 and want to get pregnant. I'm still on Opdivo and the occasional brain scan. As a result, I've been told I cannot get pregnant. So that I'll take that. I have never heard of that, where you cannot get pregnant on the immunotherapy. Have you heard anything from other panelists?
I think for other immunotherapies, the product label does say it's come up more for cemiplimab, and they say wait at least 4 weeks, but I can double check on that.
So I don't think that's out of country.
There is a slight risk of like, isn't there a slight risk of mother to baby transmission? So then the question becomes, like, there's some case reports that talk about mothers who've had more advanced melanoma and that babies are born with it.
There have been
And it's rare,
very, very rare.
but I think when I counsel younger women, I tell them about this relatively rare and then have like a discussion about carrying their own child.
But I have had patients who've been successfully treated immunotherapy who not pregnant and have children.
Yeah, I also have a discussion with my patients, my young patients, even though, like I said, it's, I haven't seen, like you said, it's not, you can get pregnant. I always, have a discussion about like oncofertility with my, my young patients.
This is question is to Dr. Ye. Strategies to prevent, sorry. Is that vaccinations or strategies to prevent melanoma, i.e. vaccine therapy.
Vaccines. Thank you. I think that might have been misleading. I was speaking about vaccines with regards to carcinomas. So like HPV vaccination can prevent carcinomas of genital skin. There are also melanoma vaccines that are being studied for immunotherapy of advanced melanoma, but there's no vaccine to prevent melanoma.
To Dr. Linden, can photodynamic therapy actually cause skin cancer?
That's a good question. We don't have evidence that it causes skin cancer. We use it to treat the precancers, mainly the actinic keratoses. And you can show that if you treat a field that you're gonna, with the photodynamic therapy, that you're going to decrease the number of precancers and therefore the number of skin cancers are gonna form in that area. You usually only do the photodynamic therapy once a year at most, maybe some people do it twice a year. I only do it like once every 1 or 2 years. Often I only do it like one time and that's enough. So we don't have any evidence that it's going to cause skin cancer. It works by different mechanisms. It kind of causes a sunburn reaction. You think, oh, this is very similar to sunburn I got, but it works by a completely different mechanism and it doesn't really damage your DNA. So I don't think it's likely to do that, but it's not impossible if you got photodynamic therapy every month that in 10 years, maybe it could have damaged the cells enough to, because it does produce singlet oxygen, which is a damaging form of oxygen that could certainly damage the DNA. So I really wouldn't worry about that.
And another question for you, Ken, is can you comment on the topical treatment with tirbanibulin?
Tirbanibulin, yeah.
Place here.
Yeah, so that's a microtubule inhibitor. It's FDA approved for treating the precancers, the actinic keratoses, like the imiquimod and Epidex that we talked about. It's just another agent that basically destroys precancerous cells. That's a reasonably good agent. It's kind of more limited in that you can only apply it to a certain amount of area. I don't use it much because I don't think it has any particular benefits over 5-fluorouracil topically, but it's a fine agent. I mean, it is FDA approved for treating precancers.
This is actually more a comment than a question, but with the recent change in administration and DOGE cuts, what is it? The likelihood to impact clinical trials and research at UCI? That is just a comment. Associate Director for Clinical Sciences here in the Cancer Center. It's a significant concern. So the proposed cuts and the indirect rates to our researchers is from our current 59% to 15%. So you get direct costs, the grant, but the institution also needs to pay for facilities and this, that. So that's a significant cut. So if you get a chance, please contact your congressman and advocate that we need to continue our research efforts here. To Dr. Linden and Dr. Tran, are imiquimod and oncolytic therapy as effective in patients with autoimmune disease?
So I mean, I have never had any issues giving oncolytic therapy, or imiquimod patients on an autoimmune disease in my experience. You know, they can be a potential systemic, effect with oncolytic, but it's usually pretty, local.
I agree. So, more of the concern actually is with intravenous immunotherapy that we give. So we're very cautious about administering people who have severe autoimmune disease.
I mean, the imiquimod is an immune stimulating agent, and if you have an autoimmune disease, that's your immune system out of whack. And certainly if you apply imiquimod to a large portion of the skin, sometimes people develop flu-like symptoms because of it, because it is stimulating your immune system, kind of like a virus does when it attacks you, like the flu virus. So you can kind of feel like, okay, my body's reacting to the imiquimod like it would to a flu virus. So I wouldn't say completely rule it out. I probably would not be my first line treatment in a person with an autoimmune disease is to use imiquimod. I probably would use something like 5-fluorouracil, which is not immune stimulating. It basically attacks the cancers and precancerous cells themselves if you want to use topical therapy.
The final in-person question is, what are the red flags that might signal a recurrence? I'll leave that to any of the panel here.
So, I always, I watch my have them come, you always see your dermatologist and your surgical oncologist every like 3 to 6 months, depending on your stage and, to the extent of disease on presentation. Just seeing them for routine skin exam from head to toe, filling in nodal basins. In my practice, I actually do a scan of my patients about once a year, just to make sure there's no recurrence anywhere else in the body, because I tell my patients, I can see your skin, I can feel your lymph nodes, but I can't see inside your body. So I usually in my practice, I do a scan about once a year. There's not going to be anything like, oh, I feel a tingling sensation and I came back. Like there's not really going to be a sign. Like some patient could be as indolent as like I do a scan and all of a sudden, I know one of my patients, we were actually doing scans every 6 months. Actually, it's a patient I shared with Dr. Chao, every 6 months. And then at 4.5 years, he's almost at the 5 years mark. At 4.5 years, disease everywhere. And then we were doing scans every 6 months. So there's really no signs, really. I think it's just making sure you see your, surgical oncologist, you see your dermatologist routinely, and just be on top of things. I think if you notice, like instead of waiting to for your next appointment, I tell my patients, if you notice a new lump that's like wasn't there before, you might think it's just a pimple, just come see me. Just go see your physician. It could be recurrence. It can be kind of sneaky sometimes.
You can. And we just frequently do imaging and try to catch it early where we can address it before it's widespread.
So from the skin standpoint, you obviously just want to look at the area where you had your skin cancer and you see any signs along the incision lines. It is like was said, are there any lumps, bumps? If it's melanoma, are there any dark spots next to it that are forming, like we saw in that one patient where they cut it out on the neck, the shoulder ridge there, and it came back little dots there. You want to keep looking for those things. That's why at our melanoma center and most melanoma centers, once you've had a substantial melanoma like stage 1 or worse, then they're going to want to see you about every 3 months for the first 2 years and 3 or 4 months, depending on which melanoma center you're at. And then between 2 years and 5 years, every 6 months. And then after 5 years, at least yearly for life. Because what they're doing is they're looking at your skin, make sure you don't have any recurrences, you don't have any new melanomas. Because once you've had one melanoma, your risk of getting a second brand new one is about 1 in 10. And also they're feeling your lymph glands. If you've had a stage 1 melanoma, it's not so much important for stage 0, because like I say, that shouldn't be able to spread to lymph glands, but still we feel your lymph glands to make sure that you're not developing any lymph node involvement of the melanoma that was there.
There is an online question. It's for Dr. Vadia. Can you comment on the improvement in the 5-year survival? Was it 5-year?
May I read it? I'll just read it.
Sure, please. Thank you.
Would you comment, please, on the 5-year percentage rate improvement with neoadjuvant, then surgery for stage 3 melanoma.
Yeah, so we don't have it yet essentially. So these trials came out in 2023, 2024. So as we have the 2-year event-free survival and the 1-year event-free survival, but as the long-term data comes, we hope to answer that question.
I'll take an advantage and prerogative to ask Dr. Ye about prevention. So sunscreen, SPF 30, is that adequate? Do we need SPF 50, even higher?
I think SPF 30 is adequate. You're supposed to apply liberally, so a lot of people don't apply enough sunscreen to their skin and then reapply every 1 to 2 hours. Of course, sunscreen is not perfect, so shade and protective clothing are also important.
And do you do the analysis in the lymph nodes? Okay, so can you comment now, since we are now moving to this neoadjuvant approach for basically all stage 3, about how you have to look at the lymph nodes now, because that's so important, as evidenced by the NCI-designated trial, that patients who have a major pathologic response, they don't need any additional immunotherapy.
Yeah, so typically when we get the lymph nodes, we have the skin that's surrounding the primary site, and then we have the lymph node. Now that we're having to review the lymph nodes for pathologic response, there's a more complex mechanism of taking the tissue and dividing it into pieces and sampling it more adequately and quantifying the amount of response. So it does increase kind of the burden on pathologists to do that analysis.
And it's just gonna be more and more as we move forward, it seems to be.
It's gonna be more and more, yeah.
Need more dermatopathologists.
More dermatopathologists.
Okay, are there any additional questions? We have
I have a question.
Dr.
for-
Dodd,
right
he's.
Yeah, given the fact that we don't have that survival analysis, right? And from 1801, we could say that immunotherapy pre-surgery is better than post, or a little bit pre is better than totally post, right? We could say that much. What is are you using pretty much all single agent immunotherapy? This is a question for Dr. Chao too, and for everybody else too. What are you guys using? Just Keytruda or Pembro, or are you using combination therapy? Are you just deciding based on the day or time?
Wednesdays.
How are you deciding?
Wednesdays is good.
Wednesdays?
In Irvine, no.
More of a attack this
I
one
would
first.
say the majority of my patients who come in and have clinically detectable stage 3 disease, a lot of them are in their 80s or late 70s and have significant concerns about toxicity. And so I opt typically for the Keytruda for these patients just because the grade 3 side effects are less. But for the younger patients, I do have that discussion, and I like doing the Ipi-Nivo. But then after, in that adjuvant setting, I still feel like a lot of patients need the adjuvant treatment, and we don't have the long-term data yet to really feel confident.
And
Just observing.
So you're basically, after you finish the 2 cycles, somebody has a complete pathologic, or 3 cycles has a complete pathologic response. If you've done single, are you still doing?
I will talk to them too and do some shared decision making, but for the patients that I've had here, there's been an indication for therapy after. I've had different experience.
I
Yeah.
completely agree with Dr. Vadia. Then we'll move on to how UC San Diego does this. But I completely agree with Dr. Vadia. I've offered ipilimumab and nivolumab based on the NCI-designated trial to a couple patients, with the caveat that said that we only have a 12-month follow-up, and we don't know what happened after years, but the patients have declined. So fortunately, I didn't have to make that decision, but Dr. Park, Dr. Daniels from UC San Diego, perhaps you might want to comment.
Sure. I mean, my bias is to use combination therapy and neoadjuvant. And I think what drives me is the idea that if you do get a complete response, which happens more than half the time, then you're done with the new therapy. You can move on with your life. At least that's what the data reflects. So I always approach it as, can I give combination therapy? Or maybe it's saying maybe the age or something is making me pull back a little bit, but my default is combination therapy.
And so if you have a complete response, then you basically say, okay, this is it, you're done.
Yeah.
And patients are generally okay with that.
Well, we've talked about it, set it up as the expectation. And with that, I find most patients are happy about that, not having to come into the cancer center and have an infusion. So
it is very possible that the San Francisco crowd's risk tolerance is different than the San Diego crowd.
That's why we had two states here in California, right?
Discussion on these.
It's because sometimes, I mean,
Yeah.
I've had the same
Yeah,
discussion and sometimes patients will be like, well, you said this was such a serious problem, you know.
yeah.
You're
I mean,
talking
if they
about-
have the waves to distract them and surf, maybe it's easier to not think about it. Who knows?
but we definitely are more laid back. Accepting of life.
I look back using that robot shirt. It's great though. It's great. We have a consortium.
What about Dr. Park? What's your approach? Are you?
So I mainly treat non-melanoma skin cancer, and we've had really great success with neoadjuvant immunotherapy in that setting. So I do agree with Greg. In the melanoma space, I'm not totally convinced that adjuvant is the pathological complete response. I know it requires a careful discussion with the patient, but I often do find that, while you tell them that this is an aggressive disease, you also tell them that, chemotherapy upfront and cleared everything on the surgery, and that we don't have long-term data. But when you look at other neoadjuvant studies, PAP-CR really tends to portend a good clinical outcome. So I try to, err on the side of it being vivo if the patient can tolerate it upfront, with the goal to try to maybe not do adjuvant. Don't need it, but it's an individual discussion.
Dr. Dowd, how does UC San Francisco attack this problem?
Well, I can say that we have decided, I mean, like James can speak for this too. I do feel like the Nadina trial, I feel like there was a lack of equipoise, that's what I personally feel. Like you put too much onto the neoadjuvant arm, so it's a little hard to know what you're comparing to what. Are you comparing neoadjuvant to adjuvant? Are you comparing epi-nivo to nivo? Are you comparing post epi-nivo BRAF MEC to no post epi? There's just lots of questions being asked. I feel like 1801 was a more clear, you know what you're looking at. So I think to make a long story, yeah, I also am doing what, sometimes doing this and sometimes doing that. And after 2 cycles, I think sometimes if you have a PAT-CR, just stopping right there, sometimes not stopping if I think that there might be some chance that there's metastatic spread. So yeah, no, I wouldn't say I have a consistent plan either.
I will say if there's like an acral histology or something, I will do ipi-nivo and be more liberal with the age, the concern for toxicity.
That'll be a topic that Dr. Dowd will be discussing here after the coffee break. So any last questions? Oh, I'm
I
sorry.
just wanted to highlight the importance therefore is more precise biomarker capabilities at the stage of the surgery and even with blood to see how the immune system was responding to the therapy. And obviously a lot of us are balancing the risk benefits. Be interesting to see what kind of results the Opdualag combo, which theoretically has less, AEs as a combo regimen, might be able to do for melanoma, in that stage, for neoadjuvant as well.
And just to piggyback off that comment, and I know sometimes we often partner with our pharmaceutical partners. I think, not only biomarkers are really important, but having the opportunity to do risk adapted studies, which I think would answer a lot of these questions that were not answered in the study, are really important.
Yeah, there's a lot of, research going on in the basic science realm, trying to identify better biomarkers to identify patients with resistance. And then try to improve, how we can actually overcome that resistance. There's also a lot of research looking at, how can we be more precise in type of immunotherapy. There's a lot of types of immunotherapy, the single agent, dual agents, and how do we choose, right? So then I think I want to, emphasize, we really need to contact our congressman and just make sure we continue funding for research, to improve patient care, because there's a lot of work that can be done. I work with a lot of great basic scientists here at UCI, and I'm really excited for the work that can be done for melanoma and other skin cancers, but we have to support research.
Okay,
Chao, I have one more from
I'm
the.
sorry.
Can we do one more?
Yeah,
Do you have
sure.
time? Okay, so the question is, are there any new therapies coming for BRAF mutations that are not V600? And can you explain for the non-clinical people in the room what that sentence means?
Okay, so I'll try to field that question. So about 40% of melanomas have a mutation in an important gene called the BRAF gene. The majority of the mutations happen in the codon, the amino acid sequence of V600. Okay, so it's usually V600E or V600K. Those are called type 1 BRAF mutations. And they respond very well in general to targeted therapies, targeted BRAF. They call it BRAF inhibitor, and generally they combine with a second drug to help improve that response called MEK inhibitor. So there are other mutations though, but those are the majority of those mutations. And so the audience is asking about, are there others? So they're called type 2. Some have been tested with these BRAF inhibitors, and some have been responsive, at least preclinically, to these inhibitors, but others have not. So in terms of further research, because those are less common, I haven't heard of anything for these new ones, inhibitors for the type 2s, but maybe Dr. Ye.
Yeah, I think the BRAF inhibitors in the clinic are specifically targeted towards the BRAF V600E mutation. So there are new RAF inhibitors that can be pan-RAF inhibitors that can be effective against BRAF fusion oncogenes or the type 2, but they're still kind of in study.
And with that, we will officially adjourn for 14 minutes. Please come back here at 10:30. Restrooms are just down the hall here to your left. We have refreshments outside. Thank you.
If anyone had questions that weren't answered that you didn't want to have the whole group listen to, you're welcome to ask me if they're appropriate to me. They'll be around. Always happy to answer questions on skin cancer.
Well, I go by my sister. No one can stand me. Oh, it's just. Those are like excuses. I just get up in the morning, put my bag on, there's the house, and for what? Yes, yes, I'm used to something.
Okay, we'll go ahead and start the session 2 here of our morning patient-directed education symposium. We have a special add-on before we actually start with Dr. Dahl. We have Dr. Greg Daniels, full professor there at University of California, San Diego. And he'll kind of give us a bit of just a brief background about the genesis of the UC Melanoma and Skin Cancer Consortium. Great.
Thank you. And yeah, just get settled down. I'm an add-on in 2 minutes. They asked me to talk about what is this UC Melanoma Skin Cancer Consortium. And this came from Office of the President, as many of you may or may not know. There actually is some coordination between the UCs at multiple levels. And at the top is this Office of the President. And so some years ago, they put it on the cancer center directors to, hey, get your stuff together. And one of the ideas was to have a collaboration between the UC schools, and they set up a mechanism for that. Obviously, UC's in a bunch of different places: San Francisco, Davis, LA, Irvine, beautiful building. And we see a lot of cancers, a lot of health problems come through our UC, and it would be great if we coordinated better. And they thought, okay, what's our mandate? Well, reduce the incidence of cancer, education, which is why we love partnering with AIM and having these type of sessions. We're just thinking about maybe having some more patient survivorship type of sessions coming up. And as well as getting together on the research side, sharing our information with each other, especially focusing on those cancers and that problem where perhaps pharma is not as focused, maybe because of the rarity of the tumor or some other aspects of it. We are the best, but we're not the only ones in the UC consortium focusing on stuff. And it started off, Children's Health Group has a group, hematology has a group, pancreas, and so on. But we are the newest, and we've taken from some of their experience to come together. And yeah, so these are the mandates that we have, and these are the people that we have. And I get to introduce Dr. Dowd, who is also a professor of medicine up at UCSF, medical oncologist, a colleague who I've enjoyed really working with for these last years, and look forward to hearing your talk.
I want to thank Dr. Chao and thank Paige and Alice for all the great organization here, and great to see this wonderful building. And thank you, AIM, also for helping us to organize this meeting. So my topic is acral and mucosal melanoma, and that's a little bit different than the types of melanomas that we've been talking about just a few minutes ago. And so as Dr. Ye pointed out, so the acral melanoma is the kind of melanoma that you get on your fingernails, on your palms and soles, and you could see how some of these look like. You could see that it could be like a streak on your nail, or it could be kind of like a brownish blackish spot, and sometimes you could see like right over here, like a lesion on the side of your foot, or on on the sole part of your foot. So that's the type of melanoma that arises from non-hair bearing skin. And then mucosal melanoma is a type of melanoma that happens in your mucosa, like it could be in your sinuses, or it could be in your lip. And you can see all of these different locations. It could be in your tongue. Sometimes can happen, in women in the vulva or vagina. It could also happen in the rectum. And these have a different biology as compared to your skin melanomas. And as Dr. Ye was talking about, most cancer, we think, goes through a bunch of stages before you actually get to the cancer. And you start off from a pre-cancer lesion to, it has to go through all of these different steps, right? And it's either ultraviolet exposure that's responsible for cutaneous melanomas that causes all these different steps, like the nevus and then dysplastic nevus to the point where you have a melanoma. But right over here, you have melanomas that don't have a lot of sun exposure, just obviously based on their sites. And so I think we're still filling in the pieces with how these mucosal and acral melanomas actually come to be, what steps they go through. And if you look under the hood, today's thinking is that almost all cancers have to have a mutation to become a cancer. And so if you look at acral and mucosal melanomas, they're different. And this was a study from Australia. And so you could see that in skin melanomas, the average number of mutations is 79 for a standard garden variety skin, or sorry, 36.3 for a standard skin melanoma. Now, if you look at the eye melanomas or uveal melanomas, it's almost a very low number of mutations. But if you look at mucosal and acral melanomas, you could say that there's 10 to 20 times less mutations. But what you do see a lot in these two types of melanomas is rearrangements. And so rearrangements are kind of genetic abnormality, but not a mutation it's exactly, but the chromosomes are scrambled. And that's what we think is going on with these acral and mucosal melanomas. And so, apologize for this busy slide, but basically, if you look at the standard skin melanoma, and see if I can get the pointer to work. This one. So if you look at your skin melanoma, you can see that that's what's happening here. And all of these lines are one single tumor. And so you can see that in the skin melanoma, cutaneous melanoma, you see a lot of these lines are in this one pathway called the MAP kinase pathway. And think of it as like a pathway that the cell uses to sense the environment. And a lot of the mutations are right there. Now, if you look at the other different types of melanomas, if you look at, like, for example, here, you still see a lot of mutations and abnormalities in the MAP kinase pathway. But you do see a very different pattern from the normal skin melanoma. And if you look at mucosal melanoma right here, you can see again, similar pattern of abnormalities, lots of mutations in the MAP kinase pathway, but not as many point mutations, but a lot more of these deeper chromosomal abnormalities and rearrangements. And then if you look at your eye melanoma or uveal melanoma, you can see that almost no mutations in the MAP kinase pathway, but a different pattern of mutation. So basically just seeing that under the hood, these tumors are pretty different. The skin melanoma, your garden variety skin melanoma, looks very different once you look at the pattern of abnormalities. And again, this is just another way of visualizing that. That's the top panel is cutaneous. The middle one is acral, the third one is mucosal, and the fourth one is uveal. And so what you're seeing is that a lot of these, like this big line here, these are basically abnormalities in the chromosomes. And you could see that in the skin melanoma, you're seeing this type of pattern. But with acral melanoma, you're seeing a lot more of these different types of DNA abnormalities under the skin. And then similarly, if you look at the uveal melanoma, you're seeing like in this chromosome 8, you're seeing all of these changes there that are pretty distinctive for this type of cancer. So what does that mean in practical terms? The one kind of mutation that's abnormal and that's being targeted, and Dr. Ye's worked on that a lot, is on KIT mutations. And so if you look at mucosal melanomas arising in the vaginal area, about 25% of them will have KIT mutations. And the acral melanoma, the one that you get on your fingertips and stuff like that, that's about 15%. And the mucosal melanoma arising in your sinus is about 5%. And you don't see a lot of the BRAF mutation that Dr. Chao was talking about. About 40% or 40 to 50% of skin melanomas have this BRAF mutation, but it's only about 10% in these acral and mucosal melanomas, and about 10 to 15% will have NRAS mutations. So different pattern of mutations. And if you, again, looking under the hood to see if you biopsy patients, and if you look to see, okay, if you biopsy a patient who's had a response to treatment versus a patient who has not had a response to treatment, what are you going to see? We did this study at UCSF a few years ago with my colleague Mike Rosenblum in the skin program. And basically what you can see is that if you look at responders, they have a lot of T cells in them, and they have a certain type of T cell that have checkpoint expression, and we call them exhausted T cells just because that's an easy way of referring to them, even though they're not really exhausted in the sense that they haven't run out of gas exactly, but it's more that they have some checkpoint, they have some extra brakes on them that cancer can utilize to turn them off. And that's how our checkpoint treatments work. And if you look at what happens in, like, say, pneumonia or flu infection or something like that, when a T cell gets stimulated, or let's say you have a vaccine, or let's say you've got the flu, the T cells get activated. And then the activated T cell, once the infection clears, becomes a memory T cell. And that memory T cell can be there for the rest of your life. And that's why once you have immunotherapy, you can have a lifelong resistance to the melanoma coming back, right? But what happens in cancer typically is that these T cells get exhausted and start expressing checkpoint molecules in them. And PD-1, that's how Keytruda or that's how Opdivo works by blocking PD-1. That's one molecule, or CTLA-4, which is how the Yervoy drug works. That's a CTLA-4 inhibitor that works on that molecule. So what is currently thought is that as long as the cancer is present, you don't form these long-lived memory cells. And that's part of the problem in cancer treatment is to try to induce these cells. So if you look at different subtypes of melanoma and see how much PD-L1 expression they have, and that's a marker for the presence of these exhausted T cells, you can see that different melanomas have different numbers. So like your normal skin melanoma, about 60% of those will have PD-L1 expression. And if you look at acral and mucosal melanoma, it's about 30 to 40% of them will have PD-L1 expression. And that's how it looks like under the microscope. It just shows at the border zone between the tumor and between the rest of your body, you have this zone where you can see this type of PD-L1 expression, like you see like right here in this middle panel. And if you look at patients with acral melanoma, and this was a study that was done a few years ago now, basically, if you look at skin melanoma, if you look at somebody who's had total response to immunotherapy versus no response to immunotherapy, you can see that like a person who has had a good response to immunotherapy has a lot more T cells in their tumor versus somebody who's where the tumor is spread across the body. And you see the same thing with acral melanoma too. You see the same difference that a immune responsive tumor has a lot more T cells in it. And if you look to see how people respond, it's generally what you'd expect, that if you look at your standard skin melanoma, you can see that in a skin melanoma, this line here shows that about 40 to 50% of people will have some kind of benefit and will remain disease-free. If you look at the acral melanoma, that's the melanoma on your nails, you can see that in many ways it's similar, maybe not as good as skin melanoma. But if you look at the mucosal melanoma, you could see that with this, with Opdivo alone or nivolumab alone, you can see that patients generally don't do as well as they do with skin melanoma. And so one study I found was this Dutch melanoma study in Europe. There's a lot of countries have countrywide registries, so you can actually look up and see how people are doing. So in this Dutch registry, basically, if you look at just response to single agent immunotherapy, you could see that in skin melanoma, about 54% of patients had a response, while in acral melanoma, 34% of patients had a response. And if you look to see if they used combination therapy, the Yervoy and Opdivo treatment that Dr. Bhatia was talking about, which is becoming the standard of care now for neoadjuvant therapy, you could see that for skin melanoma, there was a 53% response versus 33% response for acral melanoma. Now, when you look at those numbers, you might be like, well, that doesn't look like it's a lot different, right? They look pretty similar whether you use single agent or not. And I think that's one of the issues with these registry studies, that we don't really know what types of patients were treated. And so we're just getting data for patients who walk in. It could be that people in this group here were maybe more advanced. And that's why, and that's why the doctors decide to give them these particular treatments, right? So I think to summarize the data from this study, the question they asked was, what was the benefit of using combination therapy over single agent therapy alone? And so here are the numbers. They had 184 patients who got PD-1 alone, and then 69 got IPI plus PD-1, and then 82 got IPI alone. And basically, here's the response data. And so you could see that from about a quarter of patients had a response to PD-1 single agent therapy, and the combination gave you about a 43% response rate. So you got some benefit from this combination therapy, and the study was presented at our ESMO meeting. And so it just shows the difference. And these differences were statistically significant. So you got about twofold more response from the combination treatment. And then if you compare them all together, here's the comparison between the combination IPI plus PD-1 treatment versus PD-1 alone. So if you look at skin melanoma, just your standard skin melanoma, seems like you do have some survival benefit, but it's a small survival benefit between the combination treatment and between PD-1 by itself. But then look here, if you look at that second row here, that's mucosal melanoma, you could see that there's a huge difference, right? So you could, that kind of suggests that for somebody with mucosal melanoma, maybe they're getting more benefit from the combination versus from the single agent treatment. And then for patients where you didn't know what the primary site was, there's a certain percentage of patients, maybe 5 to 10% of patients with melanoma, where we don't, we just find it in the lungs, or we find it in the liver, or find it somewhere else. Patient does not have a history of melanoma, or doesn't, hasn't previously been picked up with melanoma. And so in that case, you can see that there's some benefit from giving them combination treatment versus the more intense type of immunotherapy versus the simpler type of immunotherapy. And then for acral melanoma, again, in this study, seemed like there wasn't a huge benefit in giving them combination therapy versus single agent therapy. Now, I think this is up for discussion, as to these studies are retrospective and they don't quite have the same validity as a study where you do basically randomize people to treatments and flip a coin and say, okay, this person gets this treatment versus this person gets another treatment. These are retrospective studies, so I think that has to be taken into account. So one of the studies, one of the latest treatments in melanoma is this LAG-3 inhibitor. And so there was a study done of this with this combination. It's the Nivo plus Rela combination. And so in this study, they actually allowed patients with acral and mucosal melanoma to be accrued. And so if you look down here, if you look at the cutaneous melanoma, and I know this is a complicated kind of thing to follow, but if you look at the cutaneous melanoma, you could see that the combination, the Nivo-Rela combination, seemed like it was beneficial as compared, and this is the median line. So anything to the side here shows a benefit of the combination. And if you look at the acral melanoma, that's the second line here, you could see that there was some benefit too, but maybe not as much. And if you look at the mucosal melanoma, you could see that people on generally had a bigger extent of benefit. But then when you look here, so that was the, what we call progression-free survival, meaning how much time you go by without the tumor growing. But then if you look at the survival, the overall survival, you could see that maybe not so much of a benefit, right? You could see that the skin melanoma patients are right here, while the acral and mucosal melanoma patients are here. And so it doesn't seem like from this subset analysis that you're necessarily living more, even though your tumor might be responding better. And I think that's one of the challenges we have with these trials, that because so few patients with these rare subtypes of melanoma are accrued, you don't always have the statistical power to really tell for sure how much of a benefit you're getting. And another study looked at immune checkpoint blockade for these different subsets. And so they had this is from D'Angelo, and a fair number of patients, and they looked at combination therapies. And so this is what they found, that if you looked at mucosal melanoma here, the response rate for just single agent therapy was 23% versus 40% for the cutaneous melanomas. But if you looked at the combination nivolumab plus ipilimumab, it was 37% versus 60% for cutaneous melanomas. And then for Yervoy alone or ipilimumab, it was only 8% versus 21% for cutaneous melanomas. And if you look at this graphically, this is what you see. So here's the nivolumab plus ipilimumab combination. Here's the nivolumab by itself, and here's ipilimumab by itself. And you could see that the nivolumab plus ipilimumab, the more bars you have below that median line, the more response you're having. That just shows what the magnitude of tumor shrinkage is. So you could see here, like maybe about half the patients are having some kind of tumor shrinkage. But over here, you're seeing about 2/3 of patients are having some kind of tumor shrinkage. So it just tells you how much tumor shrinkage you're getting with this combination treatment. And then if you look at what's the duration, how long do these shrinkages last? If you look at for patients who are getting just the single agent therapy, you could see that generally speaking, the duration is pretty good. And then for the combination immunotherapy, the ipilimumab plus nivolumab combination, maybe about 50% of patients are getting a durable benefit. But if you look at just Yervoy by itself, it seems like the median duration of response is very low, like maybe 3 months or so. And then most people are not getting a long-term benefit from treatment. So what about giving people treatment pre-surgery, like Dr. Vaidya was talking about? The pendulum in our field is swung from doing surgery followed by immunotherapy to doing immunotherapy first, followed by surgery, for the same reason that she outlined. Basically, trials are showing that you get more bang pre-surgery than you get post-surgery. So this was a study that was done by Dr. Amaria at MD Anderson and her colleagues. And so they treated 36 patients and with mucosal melanoma, and they gave them checkpoint inhibitor therapy. Either they gave them combination PD-1, CTLA-4, that's what most patients got, or some patients got monotherapy too. And so here's the results. Basically, if you had a pathologic complete response or pathologic partial response, that's where the pathologist is looking at the slides and saying, okay, tumor is totally wiped out or tumor is still present. That's what the pathologic response refers to. You can see that you had a pretty good durability up to 5 years. That's 60 months, like in that blue line. But one thing you'll notice is that if you remember the slides that Dr. Vedias showed, basically those patients with skin melanoma are almost 90+% of them will have a durable response, based on data that we have. But here you're seeing that it's not quite as durable as the skin melanoma. So again, showing that point that immunotherapy does work for mucosal melanoma, it just doesn't work quite as well as it does for skin melanoma. And then just showing the probability of progression-free survival, and showing that if you didn't have a path response, you could see that those patients really didn't do as well. And if you had a path complete response, you did better. So what about targeted therapy? Dr. Chao was asked this question earlier about the BRAF V600E mutation, which is common in skin melanoma. In mucosal melanoma and acral melanoma, one of the common mutations is in a gene called KIT. And I want to say that maybe 10 years ago, there was a lot more interest in this field than there is today, partly because of the data that I'm showing. Well, there were 3 trials done. We were involved in doing this middle trial, or actually this trial, the Carvajal trial. And so this trial looked at a KIT inhibitor and looked to see how does it work in patients with melanoma with a KIT mutation. So what you'll notice is that if you focus on just this last line, the objective response rate, you can see that the response rate was just not as great as we see with the BRAF inhibitors. With the BRAF inhibitors, it's about in the 70 to 80% range. And here you can see that for this trial, it was 16%. And then for this trial here, the Guo et al., which was done in China, that trial was 23% response. So not quite the same magnitude of response, like maybe only a fourth of the patients having, or fourth or less of the patients having a response. And then if you look at this line here, the progression-free survival, that's how long the responses last. It's somewhere between 3 and 3.5 months. So again, not quite the same response that you get with skin melanoma with the BRAF inhibitors, And just showing this graphically that, and in this trial, you could have an acral melanoma or a mucosal melanoma, or you could even have what's known as sun-damaged melanoma, that with the KIT mutation. And you could see that, like maybe 3 or 4 patients had great responses, long-lasting responses, like this last patient with the mucosal melanoma was up to 100 weeks almost. But most people, you're talking a few weeks of response. So kind of disappointing. And I think that's led to people going back to other types of treatments. And so what about BRAF MEK inhibition in patients with acral melanoma? There was a study looking at 48 patients, and they compared acral and non-acral melanoma. That's your standard cutaneous melanoma. And so if you look at the response versus the non-response in those types, see that there's no real difference. Like the acral melanoma seem to do as well or even better, assuming that they had the BRAF mutation. Now, if you remember, the BRAF mutation is only present in about 10% of acral melanoma. So it's not like 50% like in the in your garden variety skin melanoma. And then if you look at the duration of response, it seems like, the duration of response was about the same in both the acral and in the non-acral melanoma with the BRAF mutations. So I'm gonna skip over this just only because the percentage of response is being low with the KIT inhibitors in acral melanoma. And people have looked at these different types of mutations like exon 11 or exon 13. Seems like you get better response with the KIT inhibitors with this type of mutation. And so I'm going to conclude by saying that, these are rare subtypes of melanoma that are present in only a small percentage of patients with melanoma. They tend to be not as immune responsive as your garden variety skin melanoma, but still patients can have some durable responses to either combination immunotherapy or to single agent immunotherapy. And one area we are very interested in is looking at NRAS mutations. We've done some clinical trials with non-selective RAF inhibitors. So these are RAF inhibitors that are not specific for the BRAF V600E mutation, but inhibit all different types of RAF. And so we think that you can get maybe about 30% response rate with these non-selective RAF inhibitors. The KIT mutations, it's about 10 to 20%. And back to our discussion earlier on about research and how much support research needs, I think clinical trials are needed in this group. And we're actively, and many investigators are pursuing these type of trials. So with that, I'm going to end. And thank you.
So thank you, Dr. Dowd, for that comprehensive review of those rare subtypes of melanomas. On that same flavor, that same topic, another very rare melanoma is uveal or ocular melanomas, so melanoma of the eye. And we have today Dr. Kapil Mishra. He is an assistant professor at UC Irvine in the Department of Ophthalmology, specialties ocular tumors. And so he will give us a virtual discussion. He's remote today on ocular melanomas. So Dr. Mishra, would you go ahead and proceed?
Thank you so much, Dr. Chao. Can everyone hear me okay?
Jesus, yes. Yes, we are.
Test again.
Okay. All right, well, excuse me. Thank you so much, Dr. Chao, and to the organizers, and it's a pleasure to meet you all virtually. I'm Kapil Mishra, as he said. I'm a ocular oncologist and vitreoretinal surgeon here at UC Irvine at the Gavin Herbert Eye Institute. And I have the pleasure of chatting and discussing with you all uveal melanoma, which we'll get right into it. So I have no relevant financial disclosures. So I wanted to back up a little bit, and as being the only ophthalmologist presenting today in the morning, I'd like to just talk a little bit about my field before proceeding first. So we all know how expansive oncology is and how many specialists there are in ophthalmology. We tend to be a little bit more of a niche, isolated field. We're purely outpatient, and our clinics run a little bit differently. But there is an overlap, of course, between the two fields, and that's kind of where I come in and other specialists that deal with oncology related to the eye, and we call this ocular oncology. So what is ocular oncology? So it's really a comprehensive care of cancerous, precancerous, and simulating conditions in and around the eye. And the simulating conditions is really important because we usually have a high level of or index of suspicion for any type of disease or condition in the eye that could be cancer or could be a growth underneath. So I often get involved in terms of differentiating between cancerous and non-cancerous lesions. Ocular oncology really spans all specialties in ophthalmology. Cancer does not discriminate anywhere in the eye. It can be on the eyelids, it could be in the orbit, it can be on every part of the eye, which we'll talk about in just a moment. So there are a limited number of fully trained specialists, but I would say that so many of us at the Gavin Herbert Eye Institute deal with cancer, because as I mentioned, it handles or it applies to all the specialties in ophthalmology. So we have amazing oculoplastic specialists, anterior segment specialists that deal with conjunctival lesions, and then myself with tumors inside the eye, which we'll get into more detail. So I always like to give this, slide, especially to colleagues in my specialty of ophthalmology, because it's a little bit upside down of what we typically think of, in which, we're so focused on vision and saving as much vision as possible, which understandably is obviously extremely critical for the patient. But when it comes to ocular oncology, then we have this idea that which is prevalent in the rest of medicine and oncology, that life trumps all, and then if life is saved, then we can focus on saving the eye or saving the globe, and only then, if the eye and the globe are saved, then we can really focus on vision. So we often don't think that way in ophthalmology. We're just so critically focused on the Snellen acuity chart and making sure we get the best vision as possible. But really, this is kind of the framework that us ocular oncologists think of. And as I mentioned, eye cancer is everywhere. It can grow on the surface of the eye, it can grow in the front part of the eye, but on the inside, and it can grow in the back of the eye. And on the right side of the screen, we have, kind of a cross section of the eye that has all these different layers, and really there can be something that grows in every single layer. And so unfortunately, eye cancers do not discriminate. This is a melanoma conference, so we're speaking specifically of melanoma, but there are all sorts of conditions that can affect all age groups, from infants to the elderly, all ethnicities, all parts of the eye. And as we know, this could spread to the rest of the body as well. And so just talking a little bit, the most common cancers by age: retinoblastoma in childhood, which is a white creamy lesion that causes a white reflex if you shine a light into a child, in which pediatricians are really good at screening and sending to the appropriate specialists. Young adults, we can get conjunctival tumors. So the conjunctiva is the thin sort of superficial, clear, translucent membrane on the surface of the white part of the eye. And then for patients who are a little bit older, we can have melanomas and lymphomas as well. And so this is a picture of a melanoma here, which will show lots more photos. And so I specialize inside the eye. There are all sorts of cancers that can happen in the retina. So as a retina specialist, we see a lot of growths on the retina, which many of them happen to be benign, but they could also be metastatic. Lymphoma is a large part of the conditions that I see inside the eye. And then the choroid is the layer underneath the retina. That's a highly vascularized layer with melanocytes, and it can grow all sorts of tumors, but mostly of a melanocytic origin. And so uveal melanoma is fortunately rare, but it's not too rare. I mean, this is a very populous area, and we have millions of patients around us. But it's much smaller than cutaneous melanoma in terms of incidence, and conjunctival melanoma, which we'll save for another talk, is even rarer. And so just talking a little bit about the numbers. So 8%, according to a SHIELD study in the US, have a choroidal nevus, but most people actually feel that this is underreported because the way they did the study is they only took photographs in the center of the retina. And most people feel like it could be even up to 15% or 20%. So I'm sure there are many people in this room that they themselves or know someone in which they were told they have a quote unquote mole in the back of their eye or a nevus, and their eye specialist or optometrist or ophthalmologist are monitoring them maybe once a year and just keeping track of it. And I often hear someone tell me that I've had this for 20 years. They say that nothing's changed, and that's most often the case. There is a low transformation rate into a melanoma, about 1 in 9,000, which the incident or the number does go up the older we get. But it's still very rare. And so I often tell patients that at this moment, I can definitively say that you have a choroidal nevus, but there's always a small chance that it can transform into a melanoma. So that's why it's worthwhile to keep being followed and being screened with dilated fundus exams. In the US, we have about 2,400 new cases of choroidal melanoma each year, which comes out to about 5 per million. And Only a third of these are really diagnosed as a small melanoma. We have all these criteria to really categorize the size of these melanomas, and small melanomas have better prognoses for metastasis. And really only a third of this is diagnosed at that stage. So it really does highlight the need that we screen patients and make sure, because most of these lesions are asymptomatic. So patients do not have any vision changes and could have a growth. And so showing some photos, this right here, this is a picture of the retina of the right eye. And this is a nevus, which is, kind of looks a little bit more pigmented. It's very flat. This is a very benign looking lesion that, eye specialists would not be concerned about at all. We see this all the time. And this is a ultra wide photo in which it shows a melanoma. And this is a little bit further out in the retina, but it's much thicker, it's much larger. And this is also a very easy diagnosis to make for eye specialists. And this is concerning. This would be sent to me for management. But there's this huge area in between of all these different lesions and sizes and shapes. And that's where really the expertise comes in of being able to tease apart these. And so if you kind of remember on the left, looking very flat and looking very uncharacteristic, and then to the right, looking much thicker and bigger and having kind of shapes and valleys looking more mountainous. These are the types of lesions that I mostly spend my time with patients following closely. And you can see that, it's not quite as big as the melanoma that I had shown in the last slide, and obviously looks a lot more interesting and characteristic than the nevus that was on the left side of the screen. These can be a small choroidal melanoma, or they could be a suspicious nevus or a suspicious mole. And these have been called all sorts of things over the years. A large choroidal nevus, a small choroidal melanoma, suspicious nevus, dormant, simple, and people have categorized this and all of that. And the issue with all of these names is that, if you call something a nevus, then you may not really be capturing the suspicion of the lesion. And if you call something a melanoma, then you really do have the burden of needing to treat that, and it's unreasonable to be able to watch these. And so we're a little bit more agnostic with these sorts of lesions. We can call it an indeterminate melanocytic tumor, an indeterminate choroidal lesion. And that really is just this gray area of lesions in which we're not quite sure if this is actually benign or malignant. And so choroidal melanoma, this is a photo of a choroidal melanoma that's in the center, that's extending out into the periphery. This is the most common primary intraocular malignancy. The most common tumor inside the eye actually is a metastasis. So we see lots of metastatic lesions, mostly from the lungs and the breast. As I mentioned, the incidence, 6 per million, 2,500, 2,600 new cases per year. It tends to be in patients who are older and of European ancestry or white ancestry, but it can be in all sorts of ethnicities. We take these very seriously, as many of the specialists in the audience and that are attending today know that metastatic disease is serious and hard to treat. And I'll get into a little bit about kind of teasing apart the prognostic indicators of which lesions may progress to metastatic disease. So how are these tumors detected? This is all screened, so you need a dilated fundus exam usually once a year. As I mentioned, most of these lesions are asymptomatic, and so this could be something growing, not to scare people, but it's just good to get a general eye exam in general, just to check for all sorts of conditions, macular degeneration, glaucoma, cataracts, etc. And then when you get a dilated fundus exam, just to see if there's a growth in the back. And then if it is suspicious, this is a very suspicious lesion on this photo, and so this would be referred to someone like myself. Just to add, since this is a UC symposium, they're wonderful ocular oncologists at the other UC systems that we collaborate with all the time. And so I'm just so impressed and I feel really grateful to be part of a group of fantastic individuals. One of the favorite parts of my job is that we have a lot of imaging equipment, because especially in these conditions in which it's a little bit hard to tease apart if this is a benign or a malignant lesion, we can look at it in all sorts of different ways and different lights to really be able to give us a better understanding. So these are why a lot of our eye appointments tend to be pretty long is because we're getting all these photos done, really studying them and seeing it. And so on the top left, this is a color or pseudo color ultra wide fundus photo showing a large lesion here. This was a patient of mine. And then you can see there's some fluid underneath the retina. So there's an associated retinal detachment as well. This is a autofluorescent image. This is a fluorescein angiography, and this is an ultrasound. And in the ultrasound, we can do an A scan and really get a sense of the reflectivity inside the lesion. And this is very suspicious, at least for a choroidal melanoma. But if a lesion is a little bit less suspicious than the one that I just shown, it's smaller, it has some features that we worry about, this would be an example of that. This was a nice paper by Shields in which on the top row, there's a lesion here just right next to the optic nerve in which it's a little bit pigmented. We can see on the OCT, which is a cross-section of the lesion, that there's some height to it. There's a little bit of thickness, which this is a lesion right here. Overlying it is a retina. We can look at the fundus autofluorescence here. That looks like there's some variable fluorescence suggesting that there may be some activity of the RPE, which is the layer above or below the retina, pardon me. This is an ultrasound right here, which shows, some thickness, but not really a low reflectivity, which we tend to see in melanomas. So this was appropriately watched. And because the reason we can watch these, or that we do decide to watch these, is because there is some morbidity, or there are some consequences to treating this with our local radiation techniques, because they can damage the vision. And so most of these we do tend to watch if they're on the smaller side. And in this case, this lesion grew, and you can see that it's much thicker on the OCT. It grew a little bit on the fundus autofluorescence and the ultrasound. And so then this lesion was treated. So there is an argument to watch these briefly. We watch these closely, but if there's any signs of growth, then we categorize this as a choroidal melanoma, because nevi or moles do not grow, or if they do grow, they grow at a glacial pace. And so if we watch these, the reason that documented growth and observation is reasonable is because most of these do not grow. And so if we treat all the ones that do not grow, then we're kind of over-treating patients with therapy that does damage the vision. And so there are many ways to treat this. There's observation, as I discussed, and to assess for growth. There's laser, there's radiation treatment. You could biopsy the lesion beforehand to see if there's malignant potential, but biopsy also has its risks if you're sticking a needle into the retina. And then there's enucleation or eye removal as well. And this is really a coordination with our pathologists, oncologists. We have a wonderful radiation oncology team here as well. And so we can kind of decide on treatments. So in terms of the treatment for small and medium-sized choroidal melanoma, there's radiation therapy that's localized, which is the plaque, which I'll show you some photos of, or an enucleation, in which you can take out the eye. And we've known many, many, many studies, including the Combs study, that plaque therapy is very appropriate in terms of risk of metastases and recurrence. And so globe conserving therapy, as I talked about before, of, saving life first, and then can we save the globe, or can we save the eye? And with plaque therapy, you can save the eye as well. So, this is a SEER database study in which they saw that there's an increasing rise of radiation or localized therapy in the world, and that enucleation rates are going down over time. Now, if it's a really large lesion, like a large choroidal melanoma, it's taking up, a decent size of the back part of the eye, in which there's just too much radiation that would be required, then these would get removed, and these would be amenable to enucleation. So plaque brachytherapy, I'm excited to say that with the wonderful interdisciplinary efforts with radiation oncology, that we're starting the plaque brachytherapy here at UC Irvine, so we'll be able to offer these cases. This is placing a radioactive source on the eye surface. You can see this is kind of a nickel-sized plaque lesion that has these slots for these seeds, these radioactive seeds. We use iodine-125, and there's software that is utilized in which you can custom design this plaque so that it reduces the amount of collateral damage to the rest of the eye. We usually suture this on. This is a surgical procedure. We leave it on for anywhere from 3 to 7 days. The patient may go home, or in some institutions, they spend the week in the hospital. And then at the end of that, then we remove the plaque and they go home. So this is just a very rough schematic of a lesion. This is a plaque where we actually suture it directly underneath the lesion because we want to try and minimize the radiation that gets applied to the rest of the eye. It cooks for about 3 to 7 days, as I mentioned, and then the lesion does decrease. It either decreases in size or stays the same, and we monitor that every 3 to 6 months for some time. And so with plaque therapy, we focus on trying to reduce the chance of metastatic disease, and then we try to save the eye, but vision can still be affected with plaque brachytherapy. About 50% of patients in our large trial showed that in medium-sized melanomas, 50% have vision that's worse than 2200. And that has a lot to do with radiation retinopathy, which again is another topic. I just wanted to just very quickly show a small part of a surgical video. This is when we take a biopsy during the surgery. This is really important just because we can understand the mutations and the gene expression profiling. This is sticking a 25 gauge needle in the retina. You can see that right here is the tumor. We stick in, and then this is a fine needle aspiration biopsy. We take a sample of this and we send this to a company called Castle Biosciences, as well as our own cytopathology. And the reason for this is because there's just become such a big advantage of being able to send these lesions, because they can tell us about the genetics inside the lesion, and that can help prognosticate the chances of this spreading to the rest of the body. And there are these different classes that now we stick these lesions under. There's a recent study that actually kind of combined them as class 1 and class 2, but the COAG report 1 had class 1A, in which if a tumor was class 1A, there was only a 2% chance of the eye cancer spreading over the next 5 years to the rest of the body. And then if you're class 2, then the chance of metastases is much higher. But there's such great therapies and that were presented by Dr. Vaidya and others in this symposium about ways that we can try and manage the metastases. So that's it for my talk. Happy to answer any questions or later on as well. Thank you for your time.
Welcome back to We'll favorite questions until the roundtable discussion at the end of the seminar. Appreciate that if you don't mind holding on. Next, we have Dr. Ahmed Moyaldin. He is an assistant professor in the Department of Neurosurgery, and he'll be discussing a neurosurgical intervention for brain metastases.
Thank you so much, Dr. Chao. Thank you for the organizing committee to invite me and share with you kind of our experience here at UCI. As Dr. Chao mentioned, I'm a neurosurgeon here with a primary focus on primary brain tumors, that is tumors of the brain, as well as tumors that spread to the brain, so brain metastases. The American Cancer Society and the CDC every year produce really a nice volume of data on the incidence rate of the most common cancers that we see in both males and females. And it's no surprise that we see melanoma high on that list for both genders. But I think, as you heard today, and as you heard many of the scientists and many of the clinicians with expertise in this space, that really we've had incredible advancements in the treatment of melanoma, that even though it's a common cancer, we are able to keep it under control in a very multidisciplinary way, involving multiple lines of treatment, surgery, and radiation modality. Despite that, it's still one of the most frequent tumors I encounter during surgery, in part because there is some level of tropism for these tumors. That is, there's some affinity for them to metastasize and go to the brain. Melanocytes, after all, are really cells derived from neural crest cells from the central nervous system. So in addition to lung and breast, melanoma is the third most common brain metastasis that we see go to the brain. It can cause a spectrum of symptoms. And depending on the location of the brain tumor, it can give anybody a sense of just headaches alone, or really affect some aspect of movement, arm function, leg function. In more subtle experiences, patients can have speech difficulty walking. Sometimes patients can present with seizures or altered mental status, confusion. So all these presentations really, for me, underscore the importance of when we're evaluating a patient with a tumor or a melanoma metastasis, what are really the reasons they may need surgery as opposed to continuing on with treatment or perhaps even radiation. As you'll hear from my partner, Dr. Jeremy Harris later, that we oftentimes don't have to do open surgery for these tumors. We can oftentimes just treat them with stereotactic radiosurgery. I think there's no better way to celebrate, what we do as surgeons than to really give you real life examples of patients that came to us with this. I think one of the biggest advances in how we do surgery is really come down to being very precise. You can look back at literature 10, 20, 30 years ago, and in order to really open the brain up and actually do surgery, you had to make these large, very kind of barbaric, not cosmetic incisions in order to remove tumor. But now with the advent of navigation, which is really a three-dimensional rendering of somebody's brain MRI that allows us to superimpose it on the patient's surface landmarks, we can actually very precisely make a very small incision using the patient's MRI to resect a brain tumor. And you can see here, this is a patient with the incision mapped out with critical veins that you can see here, located in the back of the brain in the cerebellum, and the tumor located very closely to these two veins. We can make that incision, make a very tiny opening in the bone, make a very tiny opening in the outer coverings of the brain, and bring that back very nicely, and then put the bone back on in a very precise way with an excellent outcome. This is a patient that had a recent diagnosis of melanoma, was 71 years old, and was diagnosed a few months before he presented with seizures. And you can see the reason why he had seizures. He had a new brain metastasis from his melanoma right here in the temporal lobe, a very seizure-prone area or a very seizure-genic area. And this MRI captures that location very nicely and shows you the swelling and edema that's around the tumor that's irritating that brain, leading to the patient's presentation of seizures. When I saw this patient in the MRI, I actually recommended surgery to remove this, probably the best way and fastest way to remove the tumor and also control his seizures. Remarkably, when he was first diagnosed, he was started on Keytruda. And within 1 month of being on it, and by the time I actually had scheduled his surgery, his tumor was actually already gone. So we didn't even have to do surgery for this patient. And like I said, this really celebrates the spirit of this conference and the multidisciplinary nature by which we are treating patients with melanoma. This is a patient who actually presented in 2018 and thought this was not a blister that wasn't healing very well, but eventually sought attention, and this returned back melanoma. He did very well after a deep wide excision of this. In 2020, he represented with disease now that spread to his knee. You can see it here on his PET scan, and was unable to walk. This required a total knee replacement. And unfortunately, this kept him in and out of ambulation for the next few years because of complications with this knee surgery, but eventually made it to 2023 where he was walking and doing very well. And I'll never forget this. He presented on Thanksgiving in 2023 with this large tumor here affecting now his right leg function based on where its location. So thinking that maybe tumor spread to his other knee, what in fact really was that this tumor was impacting and affecting his right leg function. I recommended surgery for him, and we did a very nice tailored craniotomy that you can see right here to remove the tumor. I recently saw him in clinic. This is him in clinic now, walking several years after that, doing very well. This is a patient who actually came into the ER thinking that she had a stroke. And if you look here ever so slightly, you can see a little bit of inability to kind of have a very symmetric smile on the right side of her face. She was looking in the mirror and she really thought she was having a stroke. She came in, had a full stroke workup in our ER. The stroke workup was negative, but I think the MRI was very clear why she was having this kind of face asymmetry. She had this history of melanoma that was and has been long in remission, but presented with this large, solid, and cystic mass that you can see here on this MRI. And knowing what we understand about the human homunculus and its somatotropic representation on the brain, this area right here of the brain, that's where our face function is. And if you actually move a little bit more forward, that's where speech is localized. And so this was a left-sided tumor affecting this patient's right side of the face. I recommended surgery for her, and we took her to surgery. Very nice, again, tailored craniotomy, small incision. And this is her tumor. As you can imagine, tumors are just like how we would think they are on the skin. They're also dark when we take them out from the brain with very, very pigmented appearance. This is her image before surgery. This is her image immediately after surgery on the next day with really a completely symmetric smile. Unfortunately, not all patients come to us in this kind of very controlled way. Melanoma is known to have a very unique hemorrhagic profile, and that is the tumors sometimes present and can bleed. And as a result, patients can go unconscious, they can develop seizures, they can come in extremis to the emergency room. This is a 34-year-old female who came to us with this large hemorrhage with a remote history of melanoma. But what made this case extra sensitive for all of us was that she was 32 weeks pregnant. So we had to act fast in this case. We rushed her to surgery, given the bleed and the mass effect on the brain. You can see here how irritated the brain is when her family found her unconscious. I want you to take note of this. This was an ultrasound that was done for her 1 day prior on the 16th when she came to us on the 17th. We took her to surgery, removed the tumor very nicely. Again, small tailored craniotomy. On 8/17, she came to us in the emergency department, took her to surgery. 8/23, she delivered her baby. And in September, she was already in our new hospital here, undergoing stereotactic radiosurgery for the cavity. And I think this really speaks to the multidisciplinary nature at UCI and how we really respond to every patient's needs and nuances in management. I want to end with an area that's something that's kind of very dear to my heart. I spent a lot of my training in this space. As you saw, I showed you many tumors. And classically, we've been very good as surgeons in approaching tumors from above, where most metastases go. But there are very unique cases where tumors appear in the sinonasal space, as we heard earlier, sinonasal mucosas, even melanomas of the eye. And I'll show you some rare examples of melanocytes that line, melanomas that line the inner lining of the brain. But around 20 years ago, there was a major revolution in the way we approach very challenging tumors of the base of the skull. And that included the introduction of an endoscope. An endoscope is a high resolution 4mm camera that we're able to put through the nostril of a patient and actually visualize and operate in this space from the nose without any incisions in the head, face, or cranium. As you can see, we can reach very, very challenging and deep structures in the brain that you can see here. This is the first case I did when I joined UCI in 2021. But the beauty of this approach, it really gives you a very panoramic view of the skull base to reach areas that really were not reachable before with surgery. As you can imagine, coming from this angle from above, you can only reach so much. But going through the nose allows us to reach really the base of the skull and really treat some very complex, unique lesions that we were not able to treat before. I spent 3 years of training post-residency, treating with, studying with two of the pioneers who developed this approach. What I love about this is it takes imaging to a whole new level. First of all, these are high resolution endoscopes that allow you to see microvasculature and tumor very intricately. We're able to use fluorophores. These are fluorescent dyes that allow us to visualize the tumor. We're able to render and create three-dimensional visualization and through virtual reality, model the tumor and its local vasculature. We even have a very, very tiny ultrasound that we can put through the nose and actually look for tiny tumors that could be trapped in certain areas that we can't see. This is a nice video, I think, that captures this fluorescent dye that we use now routinely when we're looking for tumors. As you can see here, we're looking with an endoscope, and you can see here the tumor is lighting up in green. You see that? So it's a very, very powerful tool that allows us to visualize things that we haven't seen before and in a very minimally invasive way. But I think the most important thing, it really has given us unprecedented access to these very, very challenging areas of the brain that were really abandoned by surgeons in the past. Here are two cases of a uveal melanoma that you can see here started in the orbit and has now spread and is now going right here in the very base of the brain, affecting the other eye. So really affecting now the other patient's, the vision out of the left eye. And so you can see this approach through an endonasal endoscopic approach really lends itself very nicely to decompression and removal of this tumor in protecting the patient's vision. This is a very challenging case and a very rare one. I've yet to see another one in all my years of training and practice. This is a 13-year-old boy who came to us with really what was thought to be a meningioma, a tumor of the outer coverings of the brain. But when we got in there and removed this, again, through an endoscopic endonasal approach, this ended up being a melanocytoma of the meninges, a very, very rare entity, but one, like I said, that would be extremely challenging to treat from the conventional surgical approaches that we approached from previously. I'd like to end with this kind of final thought. Surgery, medication, radiation, I don't see these as competing treatment paradigms. I really see them as synergistic. Everybody here is committed to the goal of every single patient. Every tumor board, all of these modalities are discussed, and we try to make the best decision for every single patient. And when surgery is the best decision, we certainly do it. And it's always complemented with both radiation and medication when possible. I want to just thank all of the faculty that you see here, and there are certainly many more that I've not listed, but these are my partners in radiation oncology that you'll be hearing from, Dr. Simon and Dr. Harris, who I work very closely with. Almost every single case that we talk about really undergoes this very, very deep scrutiny about what is the best for the patient and how we can alleviate the symptoms either with surgery or with radiosurgery or a combination of both. And here are all the oncologists and surgical oncologists and dermatologists that really are the front lines of this disease and have characterized it and have made profound leaps in how we manage this disease medically. But sometimes surgery is the right answer for certain patients given their symptoms. I just want to thank my lab, very committed to also our research on primary tumors of the brain. I think there's no greater reward than trying to help patients through surgery and through research, and that is something I'm very committed to, and I'm fortunate to be able to do that here at UCI. Thank you.
Thank you very much, Dr. Myelden.
Thank you.
For the amazing surgical patient stories. So to wrap up the conference here, pleased to introduce Dr. Jeremy Harris. He's assistant professor in Department of Radiation Oncology, and he'll discuss radiation for melanoma.
Oh, thanks very much, Dr. Chao, and to the AIM at Melanoma Foundation. This is a real pleasure. So greatly appreciate it. So backing up a bit, we often talk about radiation. Today I'm going to be talking about just the basics of radiation, as well as when we sometimes use radiation therapy for patients who have melanoma. So I want to back up a bit because we often think of radiation as something to be avoided. Certainly in contemporary culture, gets a lot of headlines, news articles. In fact, there's been studies of just the New York Times looking at radiation therapy and whether these are positive or negative stories over time. And over the past 20, 30 years, the trend has been more and more negativity. And so why on earth do we still talk about radiation therapy? What is it? How is it used in cancer? And what's its role nowadays? And so I usually start from just a very basic explanation of what radiation is. So we're usually talking about photon radiation. These are X-rays in the electromagnetic spectrum. And X-rays interact with matter. They interact with the body. They interact with cancer and tumors and other parts of the body as well. The way that they do that are multiple different ways. There are multiple different effects that have been well characterized for the past 100 years. Some of the most famous and most important in radiation are the photoelectric effect, where a X-ray will come in, interact with an electron of an atom, and that electron will absorb that energy and be expelled. Or the Compton effect, Compton scatter, where the photon is slowed down and also kicks off an electron. So the photoelectric effect is the effect that was discovered or characterized by Albert Einstein, leading to his Nobel Prize, so not general relativity. And so these are important characteristics that have been well described for the past 100 years. We know that with higher energies or more intense radiation therapy, we can deposit energy further into the body. So these are just the depth into the tissue that energy is deposited with radiation. And it has an additive effect. So if we use radiation beams from multiple different areas, that effect is cumulative. So we can use that property to carefully carve radiation around different parts of the body, around different tumors. Inside the body, radiation interacts with DNA. That is a therapeutic benefit to it. The way that it does that is it kicks off electrons that interact with water, creating reactive oxygen species. These are typically the species that interact with DNA, causing DNA damage. There are other less common ways that radiation can interact with DNA, but that's the most common. Cumulative effect of DNA damage results in cells dying. So tumor cells tend to reproduce rapidly. And in doing so, that DNA damage that they have results in cell death. We have a less intuitive sense about how radiation therapy works compared to a systemic therapy, a chemotherapy, a pill medication, or even then surgery. I think we have a really natural, intuitive sense about how all of those things work. And usually we have less of a sense of how radiation therapy works. So after we meet patients in clinic, in radiation oncology clinic, we discuss the benefit of radiation. And if we decide to pursue radiation therapy for those patients, we'll move forward with a plan. We do what's called a simulation, which is also known as a planning session. These simulations are typically involve a CT scan that is special for the radiation oncology department. different from those you might otherwise get through a diagnostic radiologist. We use that simulation to create a radiation plan, which can take a number of days, a week, or even 2 weeks before we start radiation delivery. During delivery, we usually break up radiation treatment into multiple days that can last days or weeks. And throughout that time, we will meet patients, discuss any symptoms they are having, any side effects that they're having from radiation treatment. So in that planning session, what happens during simulation? I mentioned a CT scan. It is unique and different from other CT scans because patients are in a treatment position. So in radiation oncology, we really treat from head to toe, top, bottom. And so we have to expose the area of the body that we want to treat with radiation. So if it's in the brain or head and neck, it's usually arms down. We may often make masks that hold patients perfectly still because it's very important to be in exactly the same position from planning session to every day of treatment. If it's in the chest and the abdomen, we might have patients with their arms up and create a mold to hold them perfectly still. A lot of departments use tattoos on patients. It's something that people are really familiar with, and I'll show you what that kind of looks like as well. This is what our simulation room looks like downstairs here at the Chao Irvine Center. So this is a CT scanner on the bottom left. And then backing up, this is what the console looks like in the workroom. This is what our lead therapist here at Irvine. And this is just an example of what it looks like to have your arms up and the type of body mold that's created. This is an example of like what a small tattoo looks like. So these are used as markers for where radiation plans should go to. We use these to help make the process quicker treatment. We don't use these so much anymore, but people are very familiar with what they are and what they look like. And it's just for marking purposes. So we saw a picture already, but here's 2 pictures of the linear accelerators downstairs at Chao. So this is one of the therapists at Irvine, and this is a linear accelerator. These are machines that weigh thousands of pounds, and they rotate on a chained gantry with millimeter precision. There is a table, we call it couch, that moves in and out and rotates around. So many degrees of freedom of motion for patients to move around and for the linear accelerator to move around. Getting into melanoma and why we use radiation for melanoma. It's not often used for patients who have melanoma that is not metastatic, that have early stage or curable melanoma. When it is done, it is often an adjunct to surgery. We call this adjuvant therapy when it is done with surgery. Typically, it would be after surgery. In those cases, it is a preventative measure. So surgery has occurred, the tumor has been removed. We use that radiation therapy to prevent it from coming back in that location. A couple of the indications for when we do use radiation for cutaneous melanoma after surgery. If the margin was positive and there is no option to do more surgery, we will recommend radiation therapy to that site. There's another uncommon type of cutaneous melanoma that tends to spread along the nerves. These are teeny tiny nerves that are not easily visible, but are visible under a microscope. This neurotropism, the ability or the tendency to move along the nerve sheaths. And there's a certain subtype called desmoplastic that tends to do this, is defined by this, in fact. When we do radiation for a cutaneous lesion of the skin, 2 very common regimens to perform the radiation are 5 treatment sessions or 20 treatment sessions. So this will last 2 to 4 weeks of daily treatment. This is that uncommon type of melanoma, desmoplastic. It's been well studied. It is uncommon, so it's hard to do clinical trials for this subtype of skin melanoma. But retrospective studies have been done. And for example, all comers of this type of melanoma, the chance that the tumor recurs in the same location, 24%, when radiation is not given, 5% when it is given. There seems to be a real benefit. That benefit is even more dramatic when looking at whether or not there are positive margins after surgery, or specific tumors that have perineural spread, the other indication. Another uncommon subtype of cutaneous melanoma are those that have a propensity to spread to lymph nodes of the body, rather than throughout the rest of the body. So lymph node spread has been tested in a clinical trial from the Tasmanian group TROG. They looked at patients who had skin melanomas that spread to lymph nodes and thereafter were treated with or without radiation therapy. So very basic question of whether to do radiation or not. There was a benefit to doing radiation in terms of the tumor recurring in the lymph node region, so 36 versus 21%. Notably, these studies are difficult to do, are not repeated often. So this study started in the early 2000s. It predated the use of immunotherapy for melanoma in general. It predated the use of immunotherapy for melanoma for resectable disease, where it has spread to the lymph nodes. So we're sort of in an area where the benefit to radiation for these types is not entirely known, and so is not always indicated. Moving to patients who have melanoma that has spread to other parts of the body, we use radiation therapy a lot. That's the dominant form of radiation that we are using for melanoma. When it has metastasized, it often metastasizes to the bones or the spine bones, and radiation can be quite helpful for alleviating symptoms. Most common symptom is pain. So tumors of the bone can be painful. They do cause release of cytokines or inflammatory markers and can stimulate pain receptors. In addition, tumors of the bone destroy the bone, can cause fractures. If you can imagine, a break of your bone is intuitively painful. Same type of pain with tumors of the bone. These radiation courses tend to be shorter. 1 to 10 days is very, very common. These are what these types of radiation plans look like, where there's a cumulative dose throughout the body targeting the bone. This is planned for half of the pelvis that was performed. How well does radiation work for pain? In radiation, we try to be very, very evidence-based. We really try to focus on what literature has shown us, what clinical trials have shown us. There's a wealth of data for the use of radiation for metastatic disease for bone tumors. It works about 2/3 to 3/4 of the time, helping with pain somewhat or entirely. So not everyone has pain remission after radiation therapy, but it is the vast majority of patients. We tend to see that higher doses may be more beneficial. The pain response may last longer. We call this stereotactic body radiation therapy. It's one of the more recent uses and indications of radiation, where you use a very high dose of radiation at a very targeted area, typically a smaller tumor. Brain metastases. I thought Dr. Moyalman would bring up Jimmy Carter because he was just in the news. So a very famous case. So President Carter was diagnosed with melanoma in 2015. From news articles, and this is all public information, he was diagnosed after liver biopsy or liver surgery. So at that time, the melanoma had spread to the liver as well as the brain. His first treatment for melanoma was actually radiation. It was brain radiation. And that was followed by Keytruda pembrolizumab immunotherapy. The details of all of his treatment course are not known, but he entered hospice care in February of 2023, and then finally died just a month and a half ago in December. So he survived 8 or 9 years with metastatic melanoma, which is really remarkable given how far it's come over the past decades. So talking more about brain tumors, we often are using radiation therapy because this is a very important structure of the body, and tumors that are even very small can be highly problematic in the brain. Some of the symptoms, nausea, vomiting, headache, or focal neurologic symptoms. These are things akin to having a stroke, weakness, or sensory loss. There are two flavors or forms of radiation to the brain. A radiation directed at the entire brain, we call this whole brain radiation, or more focused radiation, brain radiosurgery. These are a couple of the contemporary plans of what brain radiotherapy looks like. It does help reduce and alleviate the symptoms where there are tumors in the brain. The bigger benefit tends to be preventing new tumors of the brain from popping up or establishing. So for people who have brain tumors across all different types of cancer, whole brain radiation can cut down in half the chance that new tumors pop up. With melanoma, it tends to be more resistant to radiation therapy. And so using the low dose that's given to the brain for whole brain radiation is not as effective. And so instead, we use the high dose type of radiation therapy directed at very small tumors. We call this brain radiosurgery. Some of the companies and some of the machines are really well known. You see news articles about them, people will ask about them. Those include Gamma Knife, the CyberKnife, the ZapX machine is a more recent one, or the TrueBeam machine. And all of these deliver the exact same type of radiation that I talked about at the very start of this talk, X-ray radiation. And in fact, the exact same energy of X-ray radiation. So radiosurgery is extremely effective at treating brain tumors. Again, it's been established for decades. The first study of this that really established the doses to use for brain radiosurgery date back to the early 1990s. And in that study, tumors that were small could be killed and controlled and not come back 85% of the time with a single treatment of brain radiosurgery. The field has established and contemporized much since then. For larger tumors greater than 2 centimeters in size, we will often break up the radiation therapy and be able to achieve similar results. For very large or symptomatic tumors, we often find that the best treatment starts with surgical resection, where radiosurgery is an adjunct to the surgery that's been performed. Again, has been well established in clinical trials. This is an example of a radiosurgery plan. So on the bottom right is the cumulative dose that is delivered simultaneously to this patient. Had 11 different tumors spread throughout the brain. And what you are seeing in the videos are the profile of the radiation beam and how it carves around these individual tumors as the linear accelerator moves around the body in different dimensions. And with that, I will end, and I think questions at the end, so thank you.
So, thank you. That concludes the speakers. Just want to set talks, but we have a final thing with AIM at Melanoma, and will give us a little discussion about resources, and then we'll have a final question and answer session amongst the entire group.
You got that, continue to come in.
Okay.
Well, thank you for a few minutes of your time. Let me thank our panelists today. Those were wonderful, wonderful presentations, full of hope. The last few years there have been a lot of changes in research and a lot of changes in treatment. And to that end, AIM at Melanoma was able to hold our first survivorship symposium, a symposium dedicated entirely to survivorship care in December. And I encourage you to go to our website and see that. It was an exciting day for us to be able to host that event. But for just a few minutes, I want to tell you about our organization. And I've warned a couple people that I'm going to puff up a little bit because I'm so proud to work for AIM at Melanoma. Our organization, our foundation, it was founded by Valerie Gill 20 years ago after her daughter Charlie was diagnosed with melanoma at the age of 25. There was only one FDA-approved treatment at that time, and Charlie didn't respond to it. So after she passed away, Val was determined to found an organization that would do two things. The first is that we would fund the research that we thought was most likely to find a cure for melanoma. And as part of that, I want to tell you that we have established 5 tissue banks across the country where we're collecting primary fresh frozen tissue that we hope soon to be able to disperse to researchers. So we hope we're getting closer and closer all the time to being able to have that research that'll move us towards that goal. The second thing is something that she and Charlie certainly experienced was the need for good information that would guide them in Charlie's treatment. And so we have established a website that has wonderful information, relevant information, accurate information, and it's to this website that I want to introduce you. So,
You have to press the mouse first.
oh, I have to press the mouse first. Okay, I'm a people person and not a technology person. Yay, there we go. Okay, so by far, the most frequently visited pages are the stage and those that deal with staging, relevant treatment, side effect management, and we have a brand new section on clinical trials. And so I invite you to visit those pages. We know they have been useful to the community. We also have a service called Ask a Medical Expert. Melissa Wilson is a PA who has worked as an oncology PA for over 20 years. It is not her job to change your plan of care, but rather to help you understand test results or why your care team might be suggesting a particular plan of care. She has a way of speaking, it's very non-clinical, connects with patients. And so if you have any questions about your plan of care, we have a form that you can complete and Melissa will reach out to you and try to help you understand your plan of care. And then she decided that she wanted to do a series of webinars because she was receiving many of the same questions and AIM at Melanoma receives many of the same questions. So she has done about 20 or 30 webinars on some of the most frequently asked questions about melanoma treatment. And so those are on our website as well for you to see. You know that we have these melanoma symposiums. We co-host 10 a year. And what we do at the end of these is two things. One, this symposium and all of our symposiums are available in their entirety on our YouTube live page. So you can go, not only will you see all of these presentations, but you will also see the question and answer section. But if you'd like to see a particular presentation again, then if you wait a couple weeks and you'll come back to the web page where you signed up, all of our presentations will be edited and divided by topic and then put back onto our website where we keep them for a period of 5 years. We have a podcast called Beyond the Clinic. Our host's name is Samantha Siegel, and she is the director of survivorship care at Kaiser Permanente in San Francisco. And she is the individual who led our symposium in December. And I encourage you to visit our podcast. This podcast is about the emotional impact of a cancer diagnosis, you know, the anxiety that people feel, trying to build a supportive community, those kinds of topics. Lastly, we also have a really important section on caregiving. Somebody introduced themselves to me earlier as the individual who is impacted by melanoma. And I said, I shook her husband's hand also. And I said, I know you're impacted too. So we want to make sure that caregivers know that we're there for them, that we want to support them, and that we know that they're involved in a lot of the important decisions that are made with respect to care. And finally, I want to make sure that you know that we have Peer Connect, a one-on-one mentorship program. We have 62 individuals across the country that have trained to serve as mentors. These are people who have completed their melanoma journey, and they are now here to offer inspiration and encouragement to people who are still going through their melanoma journey. And to that program, I am happy to tell you we have added a TIL mentorship program. So we now have TIL individuals who've gone through TIL therapy who are available to talk with people who are considering or need to consider TIL therapy, to explain to them what that process was like, you know, who was most valuable to them during the period of time that they were in the hospital, what kind of support they needed when they went home. So these are the ways in which we want to support you through your melanoma journey. And so if I can guide you to anything on our website, we have a huge website. If I can be your guide, that's what I do. Once again, I'm Ann Garce-Taylor. I am the Director of Community Engagement for AIM at Melanoma. And if you will, inside your bags, inside your patient packets today, and for those of you online, you're going to receive a survey. If you can please complete your surveys, because it helps us to make sure that we are presenting the information that's most valuable to the community. And now, without further ado, let's answer those questions. Dr. Chao.
Again, I'd like to offer my profound appreciation to the faculty who presented today, gave us some amazing talks. I'm sure you all agree. Again, I want to thank the patient guests and sponsors also, and again, AIM at Melanoma. So with that, we'll wrap up the session here with a final question and answer. So I'd like to ask our session 1 and session 2 speakers that come on up and have a seat. And I have lots of questions to So first is, I think this is addressed to Dr. Dowd. How do mucosal melanoma patients get access to clinical trials, and are there any novel therapies on the horizon for mucosal melanoma?
That's a great question. You know, we're, I think there's been proposals for clinical trials for mucosal, specifically for mucosal melanoma. To my knowledge, many of the trials right now are based on, tumor mutations or certain subtypes of mucosal melanomas, and looking at neoadjuvant therapy like Dr. Beja was talking about, or looking at specific mutations. I think it is, I mean, our clinical trial system does not make it super easy for people to search for trial. So I would say maybe getting in touch with somebody either like Dr. Chao or Dr. Beja, or getting in touch with some clinical trialists at your cancer center. Maybe that's the most reasonable way of finding trials for mucosal melanoma.
This is perhaps to Dr. Mishra. Any correlation between eye color and ocular melanoma? Do we have? There you go.
Yeah, there is a association. It's pretty weak, but usually lighter color irides, which tends to be more in lighter color pigmented patients, would have a increased risk of uveal melanoma. It's not the strongest association, but there is one.
This is to Dr. Ye and Dr. Linden. Does my cutaneous melanoma make me at higher risk for other forms of melanoma?
I would say maybe slightly, but not very much. If you have a cutaneous melanoma, we don't think that there's a chance that you have some genetic predisposition to melanoma, but that's pretty small if you've had just a single cutaneous melanoma. And then the acral, mucosal, and uveal melanomas don't have the same genetic predispositions.
I agree with what Dr. Ye says. It's small. There's small increased risk of melanoma in other parts of the body, such as the eye or the mucosal membranes.
Back to Dr. Dowd. Is tebentafusp effective in rare melanoma types?
I think that's a great question. Theoretically, I think it could be effective in melanomas that have, similar, under the hood type of genetic mutation, like eye melanomas, and that's basically these very rare, blue nevus melanomas, or they're types of melanomas that are associated, like Dr. Ye was talking about, with BAP1 loss. They could actually be effective even in skin melanomas, and studies have looked at it. I think the response rate, surprisingly, is not as great in the skin as it is in the liver. And that's just because tebentafusp is often used in metastatic uveal melanomas, where, and for reasons that are not totally clear to me, the eye melanoma spread to the liver in preference to any other location. They don't spread to the lymph nodes. They don't spread to the lungs as much. While skin melanomas often spread to different organs, can spread to the liver too, but often spread to other organs. So I think it's a long-winded way of saying that as long as you have the HLA-A201, the type, you could benefit from tebentafusp or other drugs like tebentafusp, there's this drug called brenetafusp, which is a PRAME targeting agent, again, for HLA-A201, which is about 40 to 50% of the population. So could be a good choice.
For those in the online and the audience, because we didn't touch on tebentafusp, but maybe just give a short description of what tebentafusp is.
Sure. So what people think is that in the case of these of bispecific antibodies, what you can do is, we talked about how T cells get exhausted and you can block that exhaustion. You can get your T cells to react against tumors, right? But another way of doing that is to physically just harpoon the T cell and get it close to a tumor. And then once you do that, the T cells just kind of go nuts and, kill the tumor that's right next to it. So the way to do that has been explored more in lymphomas, where people have tried using this strategy. Now the problem with melanoma is that we don't have a lot of cell surface markers that you can use to harpoon T cells right next to the cell. So people have used what are known as tetramers. So they're molecules that can connect tumor cells that are expressing some little fragment of intracellular protein on the surface of their MHC molecules, and basically get T cells right next to them. And so tebentafusp is one of this class of molecules. Now, the problem with this type of targeting is that you have to have this one type of human leukocyte antigen called A201, and it's a type of antigen that's used in transplant, in kidney transplants and stuff. That's what the tumor matching refers to. So tebentafusp basically is a bispecific that brings T cells physically close to tumor cells with that, having GP100 or PRAME or some kind of melanoma antigen or shared melanoma antigen. And so I think we are hoping to have many more agents like this and maybe extending beyond the HLA-A201 subtype in the future.
Dr. Dowd. To Dr. Ye, I've heard that acromelanoma is more prevalent in people of color. Why does that apply equally to all people who are non-Caucasians?
That's a great question. It's thought to be of similar incidence across all ethnicities, but because people with European or Caucasian ancestry have more of the UV-induced melanomas, they're a larger fraction in those populations. So it's thought that everyone is kind of at equal risk for acral melanoma. And we're still trying to work to understand what are the causal mechanisms behind the disease.
Another question is, what do you think about the cause of melanoma when it goes straight to lung and was never on the skin? I'll take that. So that's called melanoma unknown primary. We presume that there was a pre-existing melanoma years ago that may have spontaneously regressed, meaning that your immune system attacked the cancer and it was limited to the skin. But melanoma, we know that it can metastasize 20 years later. Presumably that's what occurred here. Just to Dr. Moyeldin, what is the role of neurosurgery when it comes to leptomeningeal spread for melanoma?
Yeah, I actually wanted to add a couple slides on that because I think it was important, but and I apologize that I didn't. I'll make sure to have it for next year, hopefully. So let me just explain what leptomeningeal disease is, I think, so everybody can have a sense of it. Oftentimes we talk about aggressiveness or stages and spread. I'd probably say the most aggressive form when cancer spreads is when it finally reaches not just the brain, but the outer coverings of the brain, the fluid spaces of the brain, and this blocks the absorptive mechanisms of the brain to absorb, make, and recycle daily brain fluid. This becomes a very ominous clinical situation, in part because you have to remove that brain fluid on a daily basis. And if you don't, you develop this condition called hydrocephalus, which is buildup of water in the brain and CSF, and patients become lethargic, sleepy, confused, and it really affects and impacts their quality of life. So the interventions that we do in situations like that are emergent. Patients come to us in a very stuporous state, and we oftentimes have to place an emergency catheter to drain that fluid immediately. That's a first intervention. And then in the coming days, as we're evaluating the patient and as they improve, we convert that emergency catheter into a permanent shunt that allows us to drain internally that fluid. And patients actually respond very well to that. It gives them the opportunity to go get systemic treatment, whole brain radiation if need be. And in some cases, it allows us and neuro-oncologists to deliver chemotherapy through that same catheter system via either an Ommaya or a ventricular peritoneal shunt. So those are the spectrum of things that we offer patients, and they really do, change those pivotal moments.
To Dr. Moellen, perhaps also to Dr. Harris and our medical oncologist. In stage 4 melanoma after ipilimumab, nivolumab with residual brain metastasis, are there different or brain-specific treatments that show promise?
Well, I would say, I think the thing that always is a tool in our back pocket that we have is surgery. And I also add to that radiosurgery. So anything that's failed multiple lines of therapy means that really those are the two modalities that are left for us to treat. Anything that is either symptomatic or anything that is just too big for any realistic expectation that a medication or a systemic treatment will try to do. So we consult on this pretty regularly, Dr. Harris and I, and we come up with a plan that we think is best. That's oftentimes a combination of surgery and radiation combined.
I definitely agree. Thanks. The indication for radiation, the way that it works, the mechanism is independent of a lot of those immunotherapies, a lot of those chemotherapies. And because of that, it acts independently. It tends to work regardless of the tumor type or the stage or the prior systemic therapies. There are some exceptions and gradations in that, but it tends to work regardless. And so we're often using radiosurgery after prior lines of chemotherapy, after prior lines of immunotherapy. That tends to be when cancers pop up in places like the brain, the bones, other places. So yes, it will continue to work.
Maybe you can comment then on following patients with brain metastasis after definitive treatment and their MRIs, radionecrosis versus active tumor.
Mm-hmm.
Yeah, that's a challenge. So we once melanoma has spread to the brain or other cancers have spread to the brain, we are very, very cautious. We watch these patients very, very carefully. We will typically be getting MRIs to survey the response to radiation, to surgery, to systemic therapy on a very routine basis every 2 or 3 months. Following treatment with radiation, there are different types of responses that are seen. So there are times when tumors will melt away and become invisible on an MRI. These are complete responses that are easy to monitor because the MRI thereafter will be near normal. There are times when a large tumor will shrink but not entirely disappear. And in those cases, the tumor may be dead or inactive, and we'll continue to monitor If there is growth, that is when it would become concerning. Now, there's another condition where there is death around the tumor itself of the brain or supporting cells. They become inflamed, edematous, and enhance similarly to how tumors enhance. And this could be a very difficult scenario because distinguishing necrosis from a tumor recurrence is a challenge. It continues to be a challenge. There are imaging modalities that can help with that. Specific types of MRIs that perfuse these tumors. PET scans combined with MRI can help. But by and large, it remains challenging. There are treatments for necrosis, and we would typically use those to monitor response. We sometimes know to distinguish these entities based on just clinically what is happening throughout the rest of the body, throughout the rest of the brain. But yes, it's an area of research that remains difficult to know.
What is the difference between NED, no evidence of disease, and cancer-free or cured? Anybody want to take that one on?
Sounds like a good one for you, Dr. Chao.
So we traditionally, the American Cancer Society and the NCI said that 5 years is when you're, quote, cured of cancer. But with melanoma, we know, unfortunately, that recurrence more than 20 years down the line can occur. So when we say you're NED or cancer-free, that there's no radiographic evidence that we can, our best ability to detect it by PET scan or anatomic imaging with MRI or CT. We don't see it. But cancer cells are small, and a centimeter cubed or 1 gram of tissue is several billion cells. And that's our limits of detection is around half a millimeter, or excuse me, half a centimeter. So unfortunately, there's a lot of cells that could still be floating around. But traditionally we use 5 years.
I tell my patients the highest risk of recurrence is usually the first 2 years. After 2 years, I am cautiously optimistic, right? 5 years, I say, like Dr. Chao says, that's usually the magic number. I still keep an eye on my patients even after 5 years. We kind of space out the surveillance. Yeah, as opposed to every 6 months, it becomes once a year because, as Dr. Chao alluded to, it can come back after 8 years, 10 years, even 20 years. That does happen. Unfortunately, I think it's unfortunately just simply bad luck. But like I said, it doesn't happen often, but it does happen.
I'm curious if people are using blood-based minimal residual disease detection in their practice.
Yeah, well, I think the issue with the blood-based detection is the same thing that the issue with scans is. Like you could take a picture at a wedding and everybody's like nice and hugging and kissing each other. That doesn't mean that 6 months later you're not throwing plates at each other, because it's just a snapshot in time, right? So I think you could have negative
Sure.
markers.
But are you using them routinely, or
I think in Europe, it's more valid because they don't use scans as much. Here we use scans, and I think the issue with the blood-based markers is that, you can have like a small lesion in the skin, or you could, dermatologist could spot it, or you could have a brain lesion that doesn't spill over DNA into the blood, and so that could be negative. So
yeah, no, I
if you
was
mean
just
like,
curious, for the oncologist, how
if
you
you-
were using it.
Actually, I do use it in my practice, particularly patients are higher risk, those with like stage 3 disease, or getting immunotherapy. So even though they're technically NAD, getting adjuvant immunotherapy, I do. Sometimes you get these like false, like positive where it's like 0, 0, 0, then goes to like 0.1. I tend to like scan them sooner to make sure I'm not missing something, and then maybe it drops it back down to 0. But I think there's just so much we don't know yet.
And we're collecting these data to hopefully better to use these tools to help patients. So in my practice, I do use it. Obviously, if insurance doesn't cover it, then obviously we don't do the test, but it is indicated in patients getting immunotherapy for melanoma, so I do in my practice.
Maybe Dr. Vadio.
I rely
Chime in.
mostly on imaging and kind of pet and dermatology exams and making sure they have frequent visits. I've not incorporated detecting MRD yet, but I don't know about you, Dr. Chao.
I haven't, but we are, in some of our proposed clinical trials that we are doing as part of the consortium, we will incorporate circulating tumor DNA assays during your preoperative or neoadjuvant immunotherapies.
Yeah, I think,
More to come.
yeah, I think just physical exam, seeing your dermatologist, your surgical oncologist, getting scans done by your medical oncologist. And I think this is a tool that we're still learning about. I think it's promising and more research is needed.
Okay, again, my heartfelt appreciation to the faculty, to our colleagues that came down from San Francisco, our colleagues came up from San Diego. Again, our sponsors, helping Paige and Alice to help us get this organized. And again, to all the people present. So thank you once again.